And good evening, Suhana. Good evening, Mariam. Good evening, everyone. Hope I'm audible and visible. Okay, let's start today's foray. Hope you guys read about CVS and lungs yesterday and hope you have completed the chapter. We'll move on to GIT and liver. Tomorrow will be a break day, that's a Sunday. If time permits, listen to the same lecture in 1.52x. Just skip through the PDF and make sure you read all the important facts again, right? And then Monday and Tuesday, we'll revisit the other 4 chapters: kidney, GIT, kidney, male, female, genital tract, and breast. Fine. With that note, let's start. So first thing which I'm going to talk about here is about gastritis, H. pylori gastritis, and autoimmune gastritis. I had put in the WhatsApp group that I'm going to discuss these things. Some of them asked me talk about peptic ulcer also. See, please understand, peptic ulcer is nothing but retwisted H. pylori gastritis pathogenesis. Because chronic H. pylori gastritis is one of the biggest cause of peptic ulcer. Apart from that, you have the drugs, you have the stress, you have the steroids and everything, which obviously will add on to it, right? So here, primarily, we're going to talk about chronic gastritis. Before going to it, as usual, I'm going to ask you a few questions. Let's see if you can answer them, right? H. pylori gastritis is a gastritis which will be an antral predominant gastritis or body predominant gastritis. What do you guys think? Antral predominant or body predominant? Shriparna, it will be in the WhatsApp group of mine or in the PW Telegram channel. It is a we'll look into it, antral or body predominant very soon. H. pylori as well as autoimmune gastritis, both of them are chronic gastritis. Can anyone tell me what type of hypersensitivity will this autoimmune gastritis entail? Right? Is it a type 1, is it a type 2, type 3 or type 4? A very simple question. To keep answering the question, I'll ask you easier questions more, right? If I have a patient with a H. pylori and the biopsy shows H. pylori, I am not able to see them. Tell me any one stain which will help me to pick up H. pylori in the microscopy. Don't worry, Kamran. We'll talk about all of them very soon. One stain. This is a very easy question, right? One stain which can help us pick up H. pylori. A gastric adenocarcinoma, is it a chronic long-term complication of H. pylori gastritis and autoimmune gastritis? Yes or no? What do you guys think? The last question. Which of these two gastritis will also increase the risk of carcinoid tumor in the stomach? Okay, perfect. So I got few answers. Most of you are right. Some place where, yes, we didn't get the right answer. Let's go and look into each one of the gastritis here, right? Perfect. See, I have told you in the Nishchay batch, if you have any organism, I want you to have few important information in the start of it. One, talk about the transmission. Second, talk about the virulence factors. Third, if it's a microbiology exam, yes, gram negative, gram positive, everything is required. But these two are something which is very important. How do I diagnose? What is the investigation of choice? And how do I treat? If you tick all these boxes, most of the thing with respect to microbiology is done, right? So H. pylori is a fecal-oral transmission. Poor hygiene, overcrowding, and lower socioeconomic status are definitely risk factors of having H. pylori. One of the biggest advantages, H. pylori will be destroyed by the gastric acid. So hypochlorhydria, that is reduced HCl secretion, is a risk factor. Can I say that popping up all this gelusil and drinking all this antacid is a risk factor? It is definitely a risk factor, which will actually help H. pylori to survive more. In addition to, like I said, a low socioeconomic status, right? Poor hygiene. Again, all of them contributing to fecal-oral transmission, right? When the feces gets mixed with water, contaminated water, that's the reason for fecal-oral transmission, right? Virulence factors, flagella is one of the important thing. Adhesin, that's a pilar adhesin. And the most important thing, these two never forget. We have a CAG-A toxin. We have one more toxin called as VAC-A, vacuolating cytotoxin, and urease. Urease is very important, not just for the pathogenesis, even also for us for identifying the thing, right? So H. pylori can cause both acute gastritis as well as chronic gastritis. Acute gastritis predominantly antral predominant, where most of the time the organism gets more affinity to the mucus cells in the antrum. And then we have chronic gastritis, which over the period of time comes to the fundus and the body, right? Acute gastritis is different from chronic gastritis totally, right? So what happens here is, when the organisms comes into the body, my body is going to have a response to the organism. That is the reason for gastritis here. It's just an inflammation-induced ulcer or gastritis, as simple as that, right? So now let's go into the pathogenesis. If you can draw the diagram, great. Otherwise, just remember what is there below that, right? So the gastric mucosa has a mucus layer. The organism reaches the mucous layer, and reduced HCl definitely helps it because it will not get destroyed, right? It has to swim through the mucous layer. For swimming through the mucous layer, the flagella helps. That's why flagella is also a virulence factor for me, right? It swims through the mucous layer and then it slowly adheres to the mucous layer. Using the adhesins on the epithelial surface, they go and bind. That's why adhesins, the pili adhesins, is also an important factor for the virulence factor here, right? Important for the H. pylori. The moment it attaches to it, it will destroy the mucosa. But at the same time, the acidity is still there. I'm saying hypochlorhydria doesn't mean that the gastric pH will become 7, right? It's still there acidity. It will still kill the organisms, right? So to protect them from the acid of the stomach, what H. pylori does is it releases urea. So urease, the enzyme. The urease destroys acid and produces ammonia. The ammonia kind of forms a shield which covers them. Which provides a base. Ammonia is a base, obviously. If you remember your NEET UG preparation of chemistry, you will definitely remember. Something of chemistry still rolls around, right? So it forms a basic environment. So the H. pylori not just destroys them, it kind of multiplies. So this helps them to produce cytotoxin, destroy the epithelium, and also it will multiply. So it's as simple as a bacterial infection. Like my body, you can have streptococcus, you can have staphylococcus, right? The same way, I also have H. pylori. So will my body react to it? Yes or no? Just Navdeep, Siddhi, Mariam, will the body react to it? Obviously, it will react to it. That is the gastritis, right? So my organism here is destroying my epithelium, eroding the epithelium. My body will obviously react to it. It's a bacterial infection. Can we eliminate it? Easily we can eliminate it. My body will eliminate it without a problem, right? So what happens here is the H. pylori, once it destroys, if the immunity is good, most of us, if the immunity is good, it will automatically eliminate the organism. This is the acute H. pylori. I don't have a problem at all. You also sometimes, you must have had a stomach pain, stomach upset after eating street food, contaminated food. It's simple H. pylori gastritis, as simple as that. It will destroy it. I don't have a problem at all. When I'll have a problem is, 95% of them, I don't have a problem, acute infection disappears. When I'll have problems, when there's a chronicity, again and again and again, when it infects, and again without diagnosing, I pop up Gelusil, Omeprazole, Pantoprazole, reducing the gastric acidity more. That is where I have a problem, the chronicity. So chronicity is a problem. When it's chronic, it will not go and bind to the antrum alone because I have destroyed the entire mucosa. Plus, I have also given more virulence, more bacterial resistance to the organism. So it will go outside its territory. It will go and bind throughout the stomach, patchily throughout the stomach, right? It will be patchy and causes patchy gastritis throughout the stomach. Now let's go back here. The H. pylori is invading the gastric mucosa and destroying it. Can I call the destruction as atrophy? It is causing destruction or atrophy of the gastric glands. So here, throughout the body and the fundus of the stomach, it causes patchy atrophic gastritis. It will cause atrophy of parietal cells. What will parietal cells do? Parietal cell secretes acid. So it will also reduce the acid secretion, right? It reduces acid secretion. The moment acid secretion in my body reduces, what will be the reflex? That's an endocrine feedback. The gastrin secretion is increased. This gastrin secretion will actually produce more acid. Someone who asked me, I think Falak, who asked me to talk about peptic ulcer, that is the one caused peptic ulcer. Acid-induced destruction of the gastric epithelium and glands is peptic ulcer. Acid and peptic digestion. That's what peptic ulcer mean, right? How does it cause? Because, please listen to me, because quite a few of them had this query multiple times in the WhatsApp groups, right? H. pylori causes patchy gastritis. Imagine there's a gastric mucosa. Here, H. pylori is destroyed. It's patchy atrophy. Because of this patchy atrophy, I am having excess of gastrin. So what will happen? These areas, when there's no atrophy, will still produce acid, right? I do have parietal cells here. They will still produce acid. That will cause your increased acid secretion and the peptic ulcer, right? I hope it's clear. Fine? Perfect. So that's what in the pathogenesis of a chronic H. pylori gastritis. Now, how do I diagnose them? You're going to tell me how do you diagnose them, right? So diagnosis, what will be the history? Anyone? Good evening, Brajesh. What will be the history? Good evening, Unmatchable. Good evening, Blessing. History is classical. You must have experienced a peptic ulcer or an ulcer or an epigastric pain, burning sensation in the epigastrium, bloating feeling, indigestion feeling is going to be the history for both acute as well as chronic gastritis. Chronic, there'll be a recurrent history of such. That's all, right? So you'll have a burning epigastric sensation, having a feeling of bloated, acute or chronic. That's how it is. Fine. Which part blessing? Let me know. I'll explain it once again. Fine. So if I know this is a patient with gastritis and if it's coming recurrently, I will definitely require to investigate. How I'm going to investigate? The investigation is very, very simple. We have to go with initially non-invasive test. So diagnosis, investigation, we always prefer non-invasive test. In non-invasive test, and obviously I'll have invasive test also, right? In non-invasive test, we have two things. Never forget both of them. One you already know. Someone already told me. What is the enzyme? Urease. So we have a test called an urease breath test. We don't want to learn about how it has been done for now. Just remember, there's a test called an urease breath test. That will help us to use it's a carbon labeled thing which has been inhaled. Based on the radioactivity, we'll be able to say, yes, urease is present in this breath. So the organism is there in the stomach, right? Other one, again, this is also very commonly used, though not great, fecal H. pylori antigen. If it's there in the stomach, it has to come outside, right? So fecal H. pylori antigen is also a very good test for me to identify H. pylori, but it's a non-invasive test, right? Next comes invasive. Invasive by default, I have to do an UGA-scopy. In the UGA-scopy is upper gastrointestinal endoscopy. Once you do that, it automatically ends up in having, in microscopy in H&E, you can see them as a slender S-shaped organisms. Use your microbiological inputs, write them. Slender, I won't be able to see. So there are two stains which will help me to look them better. One is Giemsa, other, like you guys said, silver stain. Steener silver, Warthin-Starry, both the stains are helpful for identifying the H. pylori organism, right? It's as simple as that, right? Again, if a question on H. pylori gastritis comes, it's something which is common for microbiology, common for pathology, and common for pharmacology. Don't stop with diagnosis. Write at least a word about the treatment. You know the 3-drug regimen, 4-drug regimen, right? I'm not sure about that. Can anyone tell me what are the drugs available for H. pylori antibiotics? Write a note on that alone. Also, right? Not in elaborate, just 2-drug regimen, 3-drug regimen, write the drugs alone. If you know, trust me, most of the pathologists will not know. I know only 3-drug, 4-drug. Whatever drugs you write, I will definitely put correct, and I'll also feel happy. That's a rounded question, right? You don't do this in medicine, but for path exam, you can easily do that, right? That's about a chronic H. pylori gastritis, fine? I'm repeating once again. The organism goes to the mucosa, attaches to the mucosa, enters the mucosa, destroys them, destroys the acid to produce ammonia, which creates a basic environment that destroys helps to divide more and destroy more. Immunity will eliminate them, that is acute. But when immunity is not able to eliminate them, I'll end up in having a chronic gastritis where it will go beyond its limit of antrum, goes to the entire body, but patchily involved. Wherever it is getting involved, it will destroy and cause classical atrophic gastritis. The moment I have atrophy of the parietal cells, no acid, my endocrine feedback will work, gastrin will increase and produce more acid because it's patchily destroying. The rest of them are still normal, right? Automatically, it will produce more acid that will cause peptic ulcer also, fine? Perfect. And then we have classical history and the way to diagnose them, fine? Let's come to autoimmune gastritis. It's a combination of type 2 and type 4 hypersensitivity, right? It will start as type 4, mostly end in type 2. That's what an autoimmune gastritis is, right? You have to write the same thing if the question is an autoimmune gastritis, or there's one more name. What's the name of it? I want you guys to comment. You definitely should know the name. If you know the name, do comment them, fine? Autoimmune gastritis is a type A gastritis. In surgery, we divide them as type A and type B. A for autoimmune, type B is chronic H. pylori gastritis, right? So what happens here is, you have an autoimmune CD4 T cell. T cell is the problem. That's why it's a type 4 hypersensitive reaction. That will target my hydrogen potassium ATPase pump, which is there on the parietal cell, which destroys the parietal cell. The moment it destroys parietal cell, obviously, you know that this is my cell. This T cell is going to destroy it. It creates broken fragments. These broken fragments form the neoantigen, right? Amazing. What anemia? It is pernicious anemia. Pernicious anemia and autoimmune gastritis are synonymous. If they ask about pernicious anemia, have more emphasis on the megaloblastic anemia, right? Because of the absence of intrinsic factor. I am sure you know that, right? Let's come back to this. Destroyed parietal cells will create neoantigen. The moment new antigen is formed, this immune system does not recognize them because they are not good, right? So what they will do, they'll produce autoantibodies. Autoantibodies against parietal cell, autoantibodies against intrinsic factor, autoantibodies against your hydrogen potassium ATPase. That's why we call them, this is type 2, right? Protection of autoantibodies is a type 2 hypersensitive reaction. Destruction by T cells, cell mediated, is a type 4 hypersensitive reaction. Starts as type 4, ends in type 2, which causes more destruction. Now the concern here is the major difference between this and H. pylori gastritis. Tell me, I'm having antibodies against parietal cell. So will it destroy every parietal cell uniformly or it will patchily destroy? What do you guys think? Will the destruction be uniform or it will be patchy? It cannot be patchy, na? It has to be uniform because it is destroying everything. Every parietal cell will be destroyed, right? So here we have a pan-atrophic gastritis. It's body predominant because parietal cells are more than the body of the stomach. It's a pan-atrophic gastritis. The entire parietal cell will be destroyed. If the entire parietal cell is destroyed, what will happen to the acid secretion? Obviously, the acid will reduce a lot. If the acid secretion reduces, what will happen? It will have the same feedback mechanism of more and more and more gastrin secretion. Now here is a change. The gastrin which is being increased here, can it compensate and can it increase acid production more? Yes or no? No. This increased gastrin cannot increase acid production for the only reason I am having pan-atrophy. Entire parietal is gone, right? I cannot produce acid anymore because there is no parietal cells at all. Even if one parietal cell starts to come, antibody will destroy them again, right? So there is no increase. So what happens? Again reduced acid, again more and more gastrin secretion, right? So this loop is going to become more and more and more. So this gastrin secretion is going to cause tremendous increase in G cell hyperplasia. We know more than enough pathology to extrapolate this. If you have a recurrent hyperplasia of any organ or any cell in the body, what will be the outcome? You know that this will definitely increase the risk of your gastric carcinoid or the neuroendocrine tumor of the stomach or carcinoma, right? So it will increase the risk of the carcinoids or the neuroendocrine tumors of the stomach. As simple as that. Clear? That's the difference between this and chronic H. pylori gastritis. Chronic H. pylori gastritis will not increase and cause increased risk of carcinoid. Only autoimmune will have increased risk of carcinoid tumor, right? Perfect. Done. So in the sequence or long-term complication, any severe chronic gastritis, whatever it may be, it will cause more destruction. Whenever there's more destruction of the cells, there will be more regeneration. Whenever there's more regeneration of, here gastritis is destruction of the epithelium, right? Allow more regeneration of the epithelium. Whenever there's more regeneration of the epithelium, by default there's an increase in risk of mutations. If there's an increased risk of mutation, by default it will increase the risk of gastric adenocarcinoma without fail. Yes, Siddhi. PUD is an outcome of chronic H. pylori gastritis. It could be an outcome of chronic drug intake, chronic stress, chronic steroids, whatever it can cause. But chronically, it will cause whatever increases your acid secretion and the peptic digestion is going to cause PUD. Fine. Yes, blessing up. It should be enough. Fine. Neuroendocrine tumor will have more of chronic G cell stimulation. There are types of neuroendocrine tumor not required for now. We'll ignore them. We'll see sometimes down the road, right? It will also have increased risk of maltoma. For the only reason, I'm going to have more and more and more and more stimulation of lymphocytes, right? It arises from the repetitive stimulation of lymphoid tissue. If you have repetitive stimulation of lymphoid tissue, it will cause definitely hyperplasia. Again, the same logic. More and more hyperplasia, it will automatically cause B-cell lymphoma or a maltoma or a marginal zone lymphoma. And the most important thing is the gastric maltoma, the initial stage of gastric maltoma, it will regress after a simple antibiotic therapy. If you do an antibiotic therapy, not for the stage 3, stage 4, the first stages easily will regress because I eliminate or eradicate H. pylori, automatically lymphocytes will come down, automatically it'll come back to normal, right? Okay, that's about your H. pylori and autoimmune gastritis, right? That's the first half. Second, we are going to go to the tumors of the stomach. As usual, before going to one topic, I'll ask you a few simple questions I want you guys to answer. There is a history given of a patient having loss of appetite and early satiety in these, and I'm specifying that it's a gastric cancer. What type of gastric cancer will have loss of appetite and early satiety? Whatever comes to your mind, let me know. Which type of gastric cancer will have loss of appetite and early satiety? Second question. There's a history given of protein losing enteropathy. What will be your diagnosis? Third question. A CD117 positive gastric tumor. What is that? Great Hema. Great Sahana. Perfect. The first answer is Linitis plastica, or a diffuse type of gastric cancer which has the early satiety and your loss of appetite, right? Second, your protein losing enteropathy is diagnostic of Menetrier's disease. Never ever forget that. Third, CD117 is positive in GIST, like Amran said, it's positive in case of GIST, right? So these are few tumors which I want you to, which we'll be discussing. One is your, definitely we'll be talking about your Menetrier's disease. We'll talk about gastric adenocarcinoma, and also we'll talk about GIST, right? The first thing, we'll go to Menetrier's disease. Menetrier's disease is nothing but, it's a benign proliferation, right? It is gastric foveolar hyperplasia. Foveolar epithelium is gastric epithelium's other name. I can have Menetrier's disease in both children as well as in adults. The advantage seen in children is it is a reversible condition, right? In children, it is secondary to viral infection. It's reversible. Need not worry about it. Wait for some time. Automatically, it'll come back to normal. Don't even do an endoscopy. Wait and watch. It'll come back to normal. In an adult, Menetrier's disease due to TGF alpha mutation. Obviously, it's irreversible. A mutation happens. It cannot come back to normal, right? Both of them will have foveolar hyperplasia only. What will happen if foveolar epithelium becomes hyperplastic? A very simple question. Let's say this is my foveolar epithelium, okay? And the subepithelium, we have the parietal cells and everything. So here, this epithelium is going to undergo hyperplasia. It's going to become this thick. Subepithelium cell, parietal cells, chief cells. That's what secretes the acid and the pepsin, right? So because of the thickness, it is difficult for the acid and pepsin to come to the lumen. That is the problem here, right? Foveolar hyperplasia happens. The epithelium becomes extremely thick. Because of that, diffusion of pepsin is prolonged. It is difficult to reach the lumen. If the pepsin does not reach the lumen, can we digest protein? Yes or no? Can we digest protein? We won't be able to digest protein, right? So this will cause difficult in digestion or breaking down of proteins, right? So there'll be reduction in the digestion of proteins. When we can't digest proteins, what will do? We'll not be able to absorb, so it will be lost. That's why we have a very, very classical clinical feature. The moment you see this feature, protein losing enteropathy, okay? Protein losing enteropathy is classical of Menetrier's disease. Never forget. It can be a one-liner, it can be a viva question, right? What is the classical example for protein losing nephropathy? Anyone? Classical example for protein losing nephropathy. You know that answer, right? It is nothing but protein losing nephropathy. It's your nephrotic syndrome, that's all, right? Now what's happening is the entire stomach's epithelium is becoming more thicker. Normally itself, my stomach has rugosities. Those are the folds of the mucosa, right? So grossly what happens, ideally what's going to happen, I'm going to have thickened rugae. That's what is going to happen here, thick rugae. This thick rugae, for the person who first saw, it looks like a brain's gyre and sulci. So they call it cerebriform appearance of the stomach. Can be again a 1-mark question or a viva question. Do remember them, right? So cerebriform appearance of the stomach. What will be there when I take a microscopy biopsy? In the biopsy, same. I will have foveolar epithelium hyperplasia, right? There will definitely be increase in the number of mucin secreting glands. That's a foveolar epithelium. Not just that, See, imagine epithelium always goes up and also comes down, right? But here I don't have enough space to go down because it's not malignant. It's not yet malignant, right? So what happens is the lower part of the epithelium kind of coils like this. It cannot grow beyond the limit. So what happens? It kind of coils. Imagine it's a wire. Okay, we have a wire. We can easily explain that. The wire is going down. Beyond this, it cannot go. So what will happen? The wire will coil like this, right? That's what is going to happen here as well. We call this a very classical finding, corkscrew appearance of glands. These are all keywords. Corkscrew appearance, your cerebriform appearance, and your protein losing enteropathy. And yes, can they lead to adenocarcinoma? Yes or no? What do you guys think? It's gastric epithelial hyperplasia. Do you guys think it can cause adenocarcinoma? Yes, no, maybe? What do you guys think? Obviously, the adult variant of Menetrier can lead to increased risk of gastric adenocarcinoma. Not the children, the adults. Because there's a mutation, it is irreversible. Anything chronically, if there's a hyperplasia, you will end up in having a gastric, you'll end up in having a tumor. It will definitely cause increased risk of gastric adenocarcinoma without fail, right? So now let's go to the malignant guys. This is a benign variant and we look at malignancy. Malignancy, which is the country where you see commonly gastric adenocarcinoma? Few easy questions so that you will feel happy that you still remember pathology. The biggest concern in the last few days is I have forgotten everything. We'll make sure you remember things. Japan is the most common place, right? I have two types of classification. We call it one WHO. You will have gross classification, you'll have microscopic, but we'll rely only on WHOs. One type is your intestinal type of gastric adenocarcinoma. Other is your diffuse type of gastric adenocarcinoma. The bare minimum I expect in an exam. Tell me the types. Tell me the etiology. If you know mutation, great. If you don't know mutation, I really don't care, except for few things. Tell me the gross. Tell me the symptomatology, microscopy, markers if required, and prognosis. That's all. These are the bare minimum we require for most of the cancers, right? Now let's look at this. One is intestinal type, other one is diffuse type. By default, intestinal type is the most common subtype. Any chronic gastritis causes intestinal subtype. Both your autoimmune and your H. pylori. Smoking alcohol can cause. Menetrier's disease can cause. Smoked fish. That's the reason Japan has more intake, right? Not fish. Anything smoked, you take continuously for a period of time, it will definitely increase risk of stomach cancer, right? So what happens here is, in gross, it will produce ulceroproliferative lesion. It proliferates like this. The moment you have an ulceroproliferative lesion, will it cause tiny amount of blood loss? It will definitely cause blood loss, right? Blood loss will result in upper GI bleeding, which will cause melena. The entire outlet can be obstructed. This is obviously in the later stage. In the later stage, it can obstruct the antropyloric region and the stomach itself will kind of bulge. You will have vomiting, indigestion, lots of them. Later stage, but the early stages, the only finding is melena, which is a classical example for upper GI bleeding, right? Microscopy, it's a glandular tumor. You'll have glands. Pleomorphic malignant glands with same 4 features of dysplasia. Pleomorphism, high NC ratio, mitosis, loss of clarity. And obviously you have to add one more thing here, one more important thing, that is you will have invasion into lamina propria. The moment it goes into lamina propria, that is classical invasion for a gastric adenocarcinoma, right? So this is how your gastric adenocarcinoma looks. You draw glands, ugly looking glands, lined by ugly looking epithelium. That's a classical finding for gastric adenocarcinoma, right? Now let's go to the diffuse type. Can anyone tell me what is a mutation in diffuse type? Mutation in case of a diffuse type? It is classical E-cadherin loss or CDH1 mutation, right? So diffuse type of adenocarcinoma is due to CDH1 loss or an E-cadherin loss. What will happen when E-cadherin is lost or when the CDH1 is lost is E-cadherin has two functions. One, it's a cell adhesion molecule, right? Because of the loss of function mutation of E-cadherin or the CDH1, the gene, it will result in loss of contact inhibition of growth. I would expect this word in the exam paper. Normally, when one cell is in contact with the other cell, it will not divide because I know, okay, there is not an empty space there, I won't divide. Once the inhibition is gone, which means my body thinks that, okay, this cell is dead, so let me replace. Moment ECAT is not there, every cell is separate. So there's no one adjacent to it. They'll replace. Again, they'll become separate. Again, they'll replace. Again, they'll become separate. Again, they'll replace, right? Loss of contact inhibition of growth will result in more and more and more cell division. That's what will happen. There's an error here. They don't cause an ulcero-proliferative growth. They cause an ulcero-infiltrative growth. It's not proliferative, it's right, it's infiltrative growth. It infiltrates into the gastric mucosa. It not just infiltrates, it can spread throughout the stomach. Because it goes to submucosal plane, this ulcer infiltration type can spread throughout the stomach. When it spreads throughout the stomach, the problem is wherever cancer cell invade, you will have desmoplasia. That desmoplasia will make the entire stomach wall thick. When you have a thick wall, and we use the term Linitis plastica, like a leather bottle. It's very, very, very thick like a leather bottle. We use the term Linitis plastica. A very classical appearance. If I am the examiner, I would want you to remember this loss of appetite. Rather than asking an intestinal type, I'll fixate on this because it's a very specific symptom. Melena is not a specific symptom. Even an ulcer can cause melena. It's a very, very non-specific symptom, right? Loss of appetite, early satiety is very, very classical for an diffuse type of adenocarcinoma. You need not write diffuse type specifically. You can write gastric adenocarcinoma. That's more than enough. Hi, Anand. Okay. So microscopy, there's no ecadrin, so there'll be no glands. There's no glands, so there'll be no ducts. Without ducts, can I secrete mucin? No, these are exocrine glands, right? I can't secrete mucin. So what happens? The mucin accumulates inside the cell. The moment I have a cell like this, the moment mucin accumulates inside the cell, it becomes bigger and the nucleus pushed towards a corner, mucin is clear in appearance. So that causes a classical signet ring morphology. Again, this is something which I'd expect in the answer paper, a classical signet ring morphology of the stomach. Fine. Okay. Once you have the signet ring morphology, in microscopy, you will see clear signet rings which are separated like this. They are very separate, right? They are very, very, very separate. If they are very separate, is there a possibility they can spread? I'll answer your question, Siddhi. Anant, I am not so comfortable in Hindi. Please ask your questions. I'll definitely reply. Definitely they will spread. The moment they spread, prognosis becomes bad, obviously, right? Because of they are being separated, there's an increased chance of metastasis. I want you to remember one of the classical metastasis for diffuse gastric carcinoma is it goes to the ovary. We call them a Krukenberg's metastasis. That's a very, very classical mets for a diffuse type of a gastric adenocarcinoma. Fine. Okay. Why early satiety? The answer is simple, Siddhi. I have a very thick stomach. This stomach cannot expand. The only reason I am able to eat more is my stomach expands. That's all. Okay. Loss of appetite and loss of weight is classical for any cancer in the terminal stage. But this is the only cancer where early satiety, loss of appetite, loss of weight will happen even in the first stage. It will be very early in onset. Fine. So that's about your gastric adenocarcinoma. Few more one-liners which can come in a viva in case of gastric adenocarcinoma. Their gastric cancers can spread to left supraclavicular lymph node. Can anyone tell me what's the name of that? Left supraclavicular lymph node spread. What's the name of that? You know that? That's your Virchow's node, right? Perfect. It can also have one nodular deposits in and around the umbilicus. Does anyone know the name of that? What's the name of the deposit in the umbilicus? You call them Sister Mary Joseph nodules, right? These are two unusual presentations of gastric carcinoma, which can also be in the long answer question, right? Loss of appetite along with a supraclavicular lymph node palpable. You might not be able to relate it unless you know it. No one is going to think about supraclavicular and the stomach, but it's a very classical presentation of gastric tumors. Do remember them, right? Perfect. So we know about two of them. Now let's come to the third guy. What's your GIST? Gastrointestinal stromal tumor, right? Stroma, it is coming from, not from the lumen, it's coming from the wall. The moment it comes from the wall, they don't cause ulcers, they cause mass. That's one of the important thing. They are mass producing lesions, they are not ulcer producing lesions. They don't bleed very often. Ulcer might be due to pressure, but not the first presentation, right? And this can come in an exam. Its origin is interstitiality of Khayal or your pacemakers of intestine. That's the origin of GIST, right? GIST is usually very well circumscribed and they'll be presenting as a submucosal mass. More and more and more they become bigger. You might have some of the necrotic deposits possible. May show some cystic changes, necrosis, not always. More it becomes bigger. Ulceration, plus or minus. Ulceration also will be due to pressure atrophy. There's an underlying submucosal mass which is putting pressure on the epithelium. Because of that, I can have an atrophy. Cut surface, it's gray tan, firm. Please remember this. I'll tell you why I want you to remember this. Gray tan firm cut surface could be the classical presentation of almost every mesenchymal tumor. Leiomyoma, GIST, rhabdomyoma. Write it. It will be gray tan, it will be firm in appearance. There are few things in pathology which can be extrapolated. Please learn how to do that. Fine. Okay. So we know the origin of GIST. We know how it's going to present the gross, right? You have to know a little bit about the genetics. GIST has 3 genes. If you remember 2 of them, I'll be more than happy. You should not forget this guys. CKIT, PDGF-RA. These are very classical mutations of GIST and they are mutually exclusive, right? PDGF-RA and CKIT are mutually exclusive, not PDGF-RB. When I say mutually exclusive, if one is present, other will not be present. These 2 must to know. If you know this, I'm more than happy. SDH, succinate dehydrogenase deficient GIST. This is a loss of function mutation. So there are 3 mutations which are must to know with respect to the pathogenesis of GIST. You know that CKIT is nothing but a tyrosine kinase. Tyrosine kinase by default will increase the proliferation. It will increase the proliferation and cause the pathogenesis. Okay, we'll come to the associated syndromes last, right? So once you have the mutation, the tumor is formed. What will be the microscopy? There are multiple types of GIST. Spindle cell GIST is the most common. How do you identify spindle cells? It's not just spindle cells. Along with that, you will have vacuoles. If you see vacuoles in the cytoplasm of the spindle cell, that's a classical presentation or diagnostic feature of GIST. Epithelial also can be seen, right? It can be seen in stomach, it's a bit common. Intestine, I will have more of spindle-shaped GIST, right? Epithelial GIST is where I might struggle, you might require IHC to diagnose. Epithelioid means it is looking like an epithelial cell, might have kind of a good amount of cytoplasm, rounded nuclei, will not have a spindle-shaped nuclei. You can see the image. You draw a blue nuclei like this, that's spindle shape. If you draw something like this, that's epithelioid, right? You can easily draw this also in the exam. Need not be an artist. Just elongated blue spindle along with an empty space. Round epithelioid GIST, fine. So how do I diagnose them? The moment I think of GIST, what do we do is, we do CKIT analysis. Because that's the most common mutation by default, right? CKIT will always be positive for CD117. That's what we do. If it is CD117 positive, my diagnosis is sorted, it is GIST, I'll go and treat the patient. I don't have any problem here. If CD117 is negative, right? Only when it's negative, I go for Dodge1. I see if Dodge1 is positive or not. Dodge1 means discovered on GIST first. That's a real abbreviation of Dodge1. Okay? It's a very specific marker. If Dodge1 is positive, if it's yes, diagnosis again GIST. If Dodge1 is negative, I will eliminate. Very specific, na? I can have no negative, right? So it's negative, it is not GIST, I'm sorted. The most commonly done marker is CD117 or for CKIT, and Dodge1 is a very specific marker. You might ask me, then why do I do CD117? I can jump to Dodge1. I cannot. Because if CD117 is positive, I can correlate without telling doing molecular studies, this patient is CKIT positive. Can anyone tell me, if CKIT is positive, if tyrosine kinase is positive, what is the drug you will use to treat? We'll use a drug to treat. What is that? I know you know the answer. Tyrosine kinase positive, CKIT positive. What is the drug we use to treat them? That's actually used in the treatment of GIST also. It's the most common marker, and the importance is we can use them to treat the imatinib. This will work only in c-KIT positive GIST. Okay, GIST is a benign tumor. We do have borderline GIST. We do have malignant GIST also. You need not know about that. Just remember that it's predominantly benign, but I do have borderline malignant GIST as well. Fine. That's about GIST. So we know about GIST. We know about gastric adenocarcinomas. We know about Menetrier's disease, right? So we done a little bit of stomach, whatever is required. We saw gastritis. We saw gastric tumors, right? Now let's go to our GI, your intestine, the celiac. Celiac is my favorite. Before going to celiac, we'll ask few questions. Then we'll go to celiac disease. What is the other name of celiac disease? And what will be the clinical feature of celiac disease? The other name of celiac disease is, it's also called as gluten sensitive enteropathy, right? Perfect. Celiac disease has predisposition to few particular HLA molecules. Can anyone tell me what HLA molecules? Sprue is not the other name. I will think of gluten sensitive enteropathy. Celiac sprue is like, instead of disease, we use the term sprue, that's all. If you eat anything with the raw foods which contains gluten, you'll have an explosive diarrhea, bloating, malabsorption. That's a classical symptom of celiac disease. And the HLA molecules are, I think you've forgotten, yeah, DQ2, DQ8. Remember them because these are diagnostic of celiac disease. There are few HLAs, ignore. Few HLAs you have to remember without fail, right? Perfect. Celiac is nothing but a gluten sensitive enteropathy. Okay, fine. It's a destruction of the GIT in genetically predisposed individual who cannot digest gluten-rich foods, B, R, O, and W. Where whenever these people eat the gluten-sensitive foods, they'll end up in having a diarrhea. Two HLA molecules which are very important, DQ2 and DQ8, which are very, very important in patients with celiac disease. What is so unique about this is, your HLA and my HLA knows that gluten is something which I cannot digest. It's a non-dietary fiber. I will excrete it. But people who have this DQ2 or DQ8, when gluten breaks down to gliadin, this will bind to them. Okay, they will deamidate gliadin. Okay, tissue transglutaminase is the one which converts gluten to gliadin, and the deamidated gliadin will bind to the antigen presenting molecules, will trigger the CD4. Classical type 4 hypersensitivity, this will destroy enterocytes. Once they destroy enterocytes, we have the same routine. Now, this will create neoantigen, and the neoantigen will produce this diagnostic antibodies: anti-gliadin antibody, anti-TTG antibody, and anti-endomysial antibody. Fine, clear? The gluten will be converted to gliadin with TTG. The gliadin becomes deamidated. That will be picked up by my antigen presenting cell, and that will be present to my T cells, which trigger the CD4, destroys the enterocytes, creates a new antigen, and my body produces anti-gliadin, anti-TTG, anti-endomysial antibody, which I use it for diagnosis. That's it, fine. So clinical symptom is very simple: diarrhea, acute or chronic, based on the person consumption pattern. That's all. Steatorrhea, bloating, weight loss is seen again in a chronic person, right? Rest of the deficiencies will happen because it's due to malabsorption. These are all due to malabsorption. It's not the primary thing, but yes, if someone is saying that in spite of having the diarrhea, not diagnosed, continuously having the food, you will not be able to absorb any of the important minerals or vitamins required. So you'll have those features also on a long term, right? So what will happen in the microscopy of celiac disease? Normally what we have your crypt and villi. You have villi on top, crypt below. In celiac disease, the villi will get flattened and the crypt actually grows big. Crypt will actually become hyperplastic because crypt is the one which has stem cells. That's the one which gives more new cells. Villus atrophy, crypt hyperplasia, plus lymphocytes in lamina propria. Okay, I'm writing LP for lamina propria, right? These are classical findings of celiac disease. Lamina propria, intraepithelial, classical for celiac disease, right? How do you manage? Simple. Don't eat bro foods. Stop bro foods, that's more than enough. Gluten-rich foods you stop, it will automatically come back to normal. This is enough for celiac disease, but again, if you want to score more, you should always end up with complication, prognosis, or associated factors. Can anyone tell me any associated skin condition of celiac disease? You might have heard about that. There's one associated skin condition of celiac disease. What is that? You can have dermatitis herpetiformis because the anti-gliadin antibody cross reacts with the follicular antigens of the skin. So you'll have skin lesions, right? Classical associated finding because of cross reaction with one second, guys. Sorry guys, okay, because it cross reacts with the skin antigen, the follicular antigens of the skin, right? That's classical dermatitis herpetiformis, right? Great, Bhagavad Gule. Fine. In addition to that, there's a T cell mediated problem, right? Because the type 4 hypersensitivity, you have a very aggressive variant called an entropathy associated T cell lymphoma. This is a very aggressive lymphoma. This happens in people who still cannot stop the bro foods or they are not diagnosed. These are two things you should mention. Both of them are required. If you are preparing for NEET PG, these are two places where celiac disease questions has been asked again and again, right? Dermatitis, entropathy associated, and they also ask the DQ2, DQ8, right? That's in short about celiac disease. Clear? Any doubt? Do let me know. If not, we'll go to the next guy. The next guy is inflammatory bowel disease. Fine. Few questions as usual before going to inflammatory bowel disease. I want you guys to answer. Where do you see skip lesions, Crohn's or ulcerative? Thank you, Zain. Where do you see skip lesions, Crohn's or ulcerative? Next. Where do you see pseudopolyps, Crohn's or ulcerative? You keep commenting the answer, then we'll discuss about it soon, right? Which of these two lesions, Crohn's or ulcerative, will have transmural inflammation? Transmural is equal to the entire thickness of the bowel being involved. Which of these two can present with fissures and fistula, like anal fistula? Which of them will present? Which of these two will have increased risk of gastric adenocarcinoma? Okay, gastric adenocarcinoma is definitely by both, right? Perfect. See, if a question is asked about inflammatory bowel disease, the pathogenesis part, which is there in Robbins or any other book, is actually a overlap. I cannot exactly say it's only Crohn's, only ulcerative. We have a pathogenic model. It can be in Crohn's or ulcerative. Some we can say, yes, more common in Crohn's. Some we can say more common in ulcerative. There's no clear-cut distinction line drawn. So pathogenesis, write the same for both. Features, obviously, it's different, right? That's why it's a spectrum of disease, right? So we'll go to inflammatory bowel disease. You're given a very decent answer. Now let's see if the answers are right, right? So inflammatory bowel disease, I do have genetic predisposition. We do have an host interaction, and then obviously we have an outcome, right? Genetic predisposition, few of them which are must to mention are these three, because these have very well established literature saying that this predisposes to Crohn's, this predisposes to ulcerative colitis. NOD2 polymorphism, NOD is your NOD-like receptor, the NLR receptor, which helps in inflammasome. Because of NOD2 polymorphism, there is more inflammasome activation against commensal bacteria. If it activates against microbe causing GI, acute gastroenteritis, I don't have a problem. I'll have more against commensals. That is the problem. When the commensals are detected as foreign, my body will destroy the commensals, and unfortunately, I'll destroy the epithelium as well, right? Increase in interleukins, which is commonly seen in Crohn's. But again, if the question is ulcerative, you can write this again. Autophagy related polymorphism is ATG16L1. Okay, maybe if it's that's big, might be a bit difficult to remember. Autophagy related genes are ATG, autophagy related genes 16L1. Okay, this gene polymorphism again increases the risk of Crohn's disease. Overactivation of Th17. See, we have T cells. T cells can have Th1, Th2, Th17. Th1 is tuberculosis granuloma. Yesterday we saw Th2. Can anyone comment where do we see Th2? Th17 is this. Whenever Th17 increases, it increases interleukin 17, which causes acute or chronic inflammation. That is the reason we have crypt abscesses more in ulcerative colitis. Again, this is more commonly seen in ulcerative colitis. So these are genetic predisposition. I have an abnormal polymorphism in the receptor, I have an abnormal gene in autophagy, or I have an abnormal functioning T cell. So with this genetic predisposition, I have a host alteration. This is the most important thing. Alteration in the microbiome. Normally in your body and my body, we have a healthy amount of commensal, right? In a normal person, the commensal will be more protective for me. It will not be pro-inflammatory, it will be anti-inflammatory, right? But yeah, T2 is for allergy or asthma, you're absolutely right. In a normal person, there will be less amount of pro-inflammatory microbes. I'm not saying it will be zero. It will always a balance, right? In a normal person, if your diet is normal, if your habits are normal, you don't eat much of junk, you don't keep on drinking carbonated foods, everything is normal, you don't smoke, you don't drink alcohol, your pro-inflammatory microbes will reduce, anti-inflammatory will be more. Fine. Okay. So the great question, these are organisms, right? Can they enter into the cell? It can enter into the cell. Or the organism's byproduct can enter into the cell. Against it, what we are going to react. Fine. Perfect. Let's come to this. So normally, I'll have less of pro-inflammatory microbes because of the Western influence or an abnormal habits or an abnormal diet. Okay. Or habits. When the microbiome shifts to pro-inflammatory, plus the same people are having problems in the lymphocyte, problems in the autophagy, problems in the polymorphisms of the receptors, what's going to happen? I'm going to react more than normal, right? So when it turns pro-inflammatory, in addition to this, I have genetic predisposition, I will react differently. Either I can have ANCA positivity, that is commonly seen in ulcerative colitis, or I can have antibodies to Saccharomyces cerevisiae. That's one of the commensal. Saccharomyces cerevisiae is one of the commensal here. That is seen in Crohn's disease, right? Ultimately, what will happen? There will be more inflammation in the GIT. These inflammation, be it antibody, be it WBC, whatever it is, it's going to produce more amount of reactive oxygen species, which is going to definitely destroy the lining of the intestine. Okay, that's what's going to happen, right? In a simple normal sequence, I have a genetic predisposition, I have more pro-inflammatory microbiome, I'll have more pro-inflammatory response, which causes inflammation, which destroys the entire gut. That is classical for inflammatory bowel disease. This holds true for both ulcerative and Crohn's. It's neither only for ulcerative nor only for Crohn's. If the question is on ulcerative, emphasis on this. If the question is on Crohn's, emphasis on this, right? Change it, change the order, that's all. Based on ulcerative or Crohn's, right? Perfect. Now, to the table. We have already read that table in a very good way. I want you to remember only this guy, transmural and superficial ulceration, right? I asked this also as a question. Crohn's will have transmural inflammation. Ulcerative will have superficial mucosal inflammation. And obviously, I have the name, ulcerative colitis. It's a colonic inflammation, colitis. Crohn's can involve from oral cavity to anal canal. Because of the extensive involvement, Crohn's cannot be continuous. Imagine oral cavity to anal canal having inflammation. The patient will not survive a single day, right? So it has to have a skip lesion for Crohn's to exist. That's why we have skip lesion in Crohn's. Ulcerative can be continuous. Even if you remove the entire colon, it doesn't matter for us at all. And though I know ileum is a small intestine, I cannot say you stop there because you're colitis. I'll have backwash ileal inflammation, a classical feature of ulcerative colitis, right? The earliest finding of Crohn's disease is oral ulcers because it can involve entire GIT. The first thing any patient will see is the ulcer here, not the ulcer in the gastrointestinal junction, I can't see them. Or in the esophagus, we'll see the aphthous ulcer. When will I suspect it? If the aphthous ulcer is not responding to treatment. Not you must have got aphthous ulcer. How many of you got aphthous ulcer? If you're not got it, wait for your prelims to be announced and your university exam to start. You will have it. It's a stress-induced ulcer. It will resolve within a week. Not resolving, think of Crohn's. More than 4 centimeter, think of Crohn's. Very unusual location, like in palate or uvula. After the ulcer will happen in the lips and the gums. Unusual location, think of Crohn's. But ulcerative colitis involves only colon. I cannot have a visible ulcer. The only finding is a mucosal granularity. It has to be under, you can only identify after investigating, doing a colonoscopy. Normally, you cannot pick up mucosal granularity. It's a colonoscopic finding. When you do this colonoscopy, you can have a little bit of granularity in the mucosa. Fine. Perfect. Then, again, Crohn's is transmural. Both are chronic, right? I'm sure you will never forget this in your life because my entire life is on this. TDHF, tissue destruction, healing by fibrosis. Transmural tissue destruction causes fissure, fistula, and sinuses. Entire GIT is gone, right? So I can have fissures. I can have fistula. I can have sinuses. Possible. Anal fissure is a feature of Crohn's. It cannot happen in ulcerative because ulcerative is not transmural. And TDHF, fibrosis, will definitely cause stricture. Stricture can cause obstruction. Fine. Since it's a transmural inflammation, can I say it will reach till the serosa? The ulcers are deep and knife-like. Imagine this is a mucosa. I have deep knife-like ulceration. If you remember my lecture, I had told you that this looks like a pav bhaji buns cut, deep cut. That is the term for cobblestone mucosa. It will look like rounded spaces. If you look from the top, it looks like cobblestone. Classical finding for Crohn's disease. Okay, perfect. Again, because the inflammation is transmural till the serosa, your omentum, your mesentery will come and stop it from rupture. Creeping pad of fat. It's nothing but the mesentry's way to stop perforation. This will happen for any organ's perforation. If an organ is going to perforate, it will automatically come and seal the place. That's the function of mesentery. Remember first year, you must have told mesentery as and omentum as policeman of abdomen. When serosa is about to rupture, I'll go and cover the place, policeman. That's why creeping pad of fat. Okay. And again, since Crohn's is skip lesion, you have transmural involvement here. Again normal. Again transmural involvement. Again normal. This gives the appearance of a hose pipe. Hose pipe is nothing but the washing machine's pipe, which can expand and contract. It looks like that, a hose pipe appearance. Cross features of Crohn's. Everything is based on only one finding. Transmural inflammation and simple logic. Can destroy fissure, fistula, sinus. Heal by fibrosis, stricture and obstruction. Skip lesion because of stricture and normal. Stricture and normal looks like hose pipe. Deep transmural ulcer because of that cobblestone mucosa. Can involve the serosa. Your creeping pad of fat will come and stop it. Classical, right? Now let's go to ulcerative colitis. Ulcerative colitis is not transmural. Ulcerative colitis is superficial mucosal inflammation. That's all, right? So here, which means this is my normal mucosa, lamina propria and everything. So here, inflammation will be there, superficial and mucosal. It's ulcerative, right? So the inflammation will destroy everything. It's gone. Only the mucosa is gone. Rest of them are normal. But this ulcer is a very broad-based ulcer. It's not a very deep ulcer. It's a broad-based ulcer. Because of this ulcer, the corner, this normal mucosa, looks very big. That's your pseudopolyp. It's not a polyp. It's normal mucosa adjacent to an ulcer. Next to an ulcer, it looks very protruding. So we call it a pseudopolyp. Right? It's a continuous ulcer. So what happens? Normally you draw colon like this, right? In your anatomy, you have drawn hostrations. The ulcer will destroy hostrations. Because the hostrations are gone, it looks uniform like a lead pipe. We call it lead pipe deformity. There's hose pipe there. Here is lead pipe deformity, right? So broad-based ulcer, pseudopolyps, and there'll be no creeping pad of fat, and there'll be no fistula, no fissures, or even no strictures because it's not transmural, right? This is for superficial mucosal inflammation. One place for gross, that's enough. Microscopy. It's a chronic inflammation. Obviously, it should have granulomas, right? Ulcerative Crohn's disease will classically have granulomas, non-necrotizing, non-caseating granulomas. Again, the most important thing, this granulomas will be transmural. It will be seen throughout the intestinal layers. Can be in the mucosa, can be the submucosa, can be in the serosa. Fine. Here, the most important finding for me is basal plasmacytosis. But if you remember in the pathogenesis, I said that ulcerative colitis will have more interleukin 17 because of Th17. So I'll also have cryptitis and cryptapsis. Here it is more in ulcerative colitis. I am not saying it won't be seen in Crohn's, less seen in Crohn's. Both can have cryptitis, both can have cryptapsis, but more in ulcerative because of the Th17 response and the interleukin response. Fine, perfect, great. We know the mesotic production already. Fat and vitamin malabsorption will be there because it can involve my small intestines as well, right? It's not only involving the colon, it can involve small intestine. I can have fat and vitamin malabsorption. Smoking aggravates Crohn's. Smoking protects ulcerative colitis because whenever you smoke, be it here, allow more mucus production. The same thing happens in the GIT. So mucus here is going to line the ulcer. When it lines the ulcer completely, obviously it will have a layer of protection. So it momentarily improves the symptoms in case of ulcerative colitis. If it's asked as a reasoning why, you should be able to write why it is. Fine. Okay. Both have increased risk of adenocarcinoma. Not a rocket science. Chronic inflammation, chronic reactive oxygen species, mutation, risk of adenocarcinoma. But only one thing will have, the destruction of the neural plexus. When the neural plexus are gone, the meningeal mucinous plexus, ulcerative can destroy. We don't know yet why. It's superficial, but can destroy the neural plexus. That will affect the peristalsis. So what will happen? Part of a bowel will not move. This bowel will not move. So the whatever is there before that, now it cannot push the food outside. So what happens? That enlarges, megacolon. And there's a problem of rupture because they also have ulcers now. So I can have peritonitis. So I call it toxic megacolon, right? That's a very, very classical finding, a complication seen only in case of an ulcerative colitis, right? Disease which recurs after surgery, only Crohn's will recur because Crohn's is throughout the body, throughout the intestine. Ulcerative cannot recur. You remove the colon, there's nothing to recur there, right? Because the entire colon is gone, right? Fine. So that's the difference between ulcerative colitis and Crohn's. Again, you know the treatment for ulcerative colitis and Crohn's as well. Write a note on that in the last. What's the treatment for ulcerative colitis Crohn's? I think your 5-alpha something. I forgot that. You know the treatment. Use the treatment. Write them as well, right? Because that will complete it. Because you need a complete answer that makes the examiner feel that you're ready to become to the next step of third year final year, because that's the continuation, right? You know the abnormality here. You know the drugs here. The only thing is you should be able to correlate them and write them as well. Fine. Perfect. That's about ulcerative colitis, Crohn's, and inflammatory bowel disease. One common pathogenic event and a table, that's more than enough for us. Fine. Understood? Done? Can you go to the next one? Next one, what are you going to talk us about? Yeah, 5A. Okay, about colonic adenocarcinoma. Again, as usual, I'll ask you simple questions. Tell me what you think about it, and then let's go further. Colonic adenocarcinomas, can anyone tell me at least one syndrome which comes to your mind with respect to colonic adenocarcinoma? There are many, but at least one syndrome. At least one syndrome. At least one syndrome. You know, obviously, your FAP and HNPCC. Perfect, right? Can anyone tell me what is the problem in HNPCC? What repair mechanism is defective in HNPCC? Hereditary non-polyposis colon cancer, or the other name is Lynch syndrome. I'm sure you know that. Gardner, Turcot, great. What's problem in HNPCC? That is your problem is in your methyl mismatch repair defect, right? So if I have a question which says that this patient has a right-sided colonic cancer, what will you think of? You'll think of FAP related or HNPCC related? Answer that. I'll ask the next question. When can you diagnose, okay, this patient has an attenuated FAP? What do you mean by attenuated FAP? And when will you diagnose, okay, this patient has an attenuated FAP? Okay, next question. If you have a patient who has multiple colonic polyps, along with that, the patient also has CNS tumors like medulloblastoma, glioma, right? What will you think of? Hi, real student. Welcome back. Perfect. You answered most of my questions. Let us see if they are right or wrong. Let's definitely see, right? Perfect. Like I said, there are few things which I want in every cancer or neoplasia question. Etiopathogenesis, sporadic, syndromic, if it is there, why and how it is causing, especially in your colonic tumors, I would require your adenocarcinoma sequence, at least the FAP's adenocarcinoma sequence, then gross, then microscopy, markers if any, prognostic factors if any, fine? Perfect. Let's go through it. Always, whenever you start, I want you to start with sporadic risk factors, even though syndromic might be more exciting. Please always start with sporadic risk factors. High red meat intake along with low fiber diet. That is a very deadly combination. You can eat beef and pork, but daily you eat salad, it's not a problem. Eating beef and pork, red meat, not having good amount of fibers is a deadly combination. Tobacco, alcohol for sure, any smoked food or any chronic inflammation of the GIT, especially inflammatory bowel disease, can definitely cause, right? Then, what are syndromes? FAP is a classical syndrome which can cause cancers, right? Your familial adenomatous polyposis. I should have minimum more than 100 polyps. Just more than 100 polyps, a family history, and a documented APC mutation. I know it is FAP. FAP is, can anyone tell me what is the inheritance? Let's see if we can apply logic and tell the inheritance. What do you think is the inheritance? Inheritance? Autosomal dominant, right? If you remember your genetics, I must have told you that autosomal dominant disorders will have variable expressivity and reduced penetrance or incomplete penetrance. Attenuated FAP is nothing but incomplete penetrance. It's not reaching 100, it's 30. Along with APC mutation, I call it attenuated FAP. These are nothing but variable expressivity. It has polyposis along with osteomas and skin tumors, Gardner, right? Skin and the bones can be involved. Turcot, I remember turban, head, right? So CNS tumors along with polyposis, you think of a Turcot syndrome. We have Cowden hematomatous syndrome. If the question says colon, thyroid and GI tumor, P10 hematomatous syndrome is very, very classical. Endometrial, very classical for P10 hematomatous syndrome. Fine. Lynch syndrome is your HNPC, like you guys exactly said, methyl mismatch repair defect. MSH, MLH are the genes which is involved in the repair. If you remember that, right? Otherwise, causing it as telling it as mismatch repair or methyl mismatch repair is more than enough. The most important thing is right side colonic cancer. This also will have endometrial cancer, skin tumors, and renal pelvis tumors. The combinations are very important for me to exclude. Fine. Okay. So these are sporadic risk factors. How does it cause cancer? At least you have to write the adenocarcinoma sequence for one person at least, right? So normal mucosa will be there when there's a germline mutation. I have one mutation at birth. It won't cause cancer, not enough to cause cancer, right? I need more than one mutation. Can anyone tell me what's the hypothesis? I need two mutations to cause cancer. What is the hypothesis? So then I have the second hit in APC or beta-catenin mutation. That also is not enough for me. For my mucosa to become slightly irregular, I need KRAS mutation. KRAS is one of the important mutation which makes the mucosa from normal to abnormal. Then I have more guys. P53 will be gone. Then I'll have adenoma superficially. Telomerase will be gone. It will become carcinomatous and it will also start metastasizing. This line is very important, right? APC, beta-catenin, KRAS, P53 and telomerase. Great. That's your nuts and two-hit hypothesis. You are absolutely right. This is important. APC, beta-catenin, KRAS, P53 and your telomerase. The sequence of mutations, it's a multi-step carcinogenesis. That's very important for us to result in the cancer formation, right? So now I know the cancer is formed. What will be the clinical features? I had put clinical features first for the only reason that this is a long answer question. So I have to remember the clinical features, because if I miss the diagnosis, everything gone. The patient will have altered bowel habits, altering constipation, diarrhea, sometimes normal, sometimes abnormal. Recurrent changes in the bowel pattern, one of the classical findings. Second, iron deficiency anemia, especially in elderly. 40-year-old iron deficiency anemia, I won't mind. Could be due to menstrual cycle or food. 60, 65, iron deficiency anemia. Very unlikely, because if it's a woman, menstruation would have stopped. There's no reason to lose blood. And if someone has had good food till 60 years, they won't have dietary deficiency after 60 years suddenly, right? Elderly person presenting with IDA, the reason is tiny amount of blood loss keeps on happening slowly, occult blood loss. We call it occult bleeding, which results in IDA. If there is an elderly person with iron deficiency anemia, the next step is to do a stool examination to see for occult blood in the stool. If the stool examination says that occult blood is positive, automatically I want you to do colonoscopy, and then you can easily diagnose that if there is a colonic tumor or not. As simple as that, right? Perfect. So we know the clinical features, we know the etiology, we know the pathogenesis. Then let's go to gross. In gross, there are two things here. One is right side of colon, the other is left side of colon. Can anyone tell me what will be the finding in a right side colon or a proximal colon? Distal colon is left side, right? Why is right side colon? In right side colon, what will you have? In the right sided colon, we generally will have an ulceroproliferative lesion. It grows too much into them, right? An ulceroproliferative lesion, a fungating mass will be the presentation for right side of colon. Only in the terminal stage, very, very, very rarely it can obstruct. Very rarely it can go to the entire thing and it can cause obstruction, which will be easily T3, T4. Because colon is huge, right? It cannot completely obstruct it. Very rarely it will obstruct it, right? On the other hand, left-sided tumors, the distal colon tumors, are generally infiltrative and fibrosing. They go into the wall most often, okay? When they go into the wall, there will be circumferential wall thickening and the lumen will narrow. This can have increased risk of obstruction. Okay, because it's a stricture. Stricture can obstruct most easily than a tumor completely blocking the lumen, right? Perfect. So this left-sided colon cancer has few names which I want you to remember. Imagine it's like this, normal colon, okay? And this normal colon is having strictures. Stricture is happening in the wall. Because of infiltration, the wall is narrowing and I am having stricture here. So now what happens? The colon is kind of become narrow in the center. This has two names. One, we call them a napkin ring lesion. If you've gone to big hotels, they'll have a napkin and they'll have a ring. The ring will constrict the napkin. Here there'll be a napkin. Here there'll be a napkin, right? It's a classical finding for napkin ring lesion, right? The same finding can also be called as apple core lesion, right? In barium studies. We have barium enema. When you give barium enema to this patient, what happens is the narrow center alone barium will pass. Barium cannot pass in the wall. It will pass in the lumen, right? So when you do a barium enema, how it will exactly look is, it will exactly look like this. This is the entire place where the barium is seen. Does it look like apple after biting? You bite and eat the apple, the center part alone will have it, right? That's your classical apple core lesion. Both of them are other names for your left-sided distal colonic tumors. Apple core lesion and your napkin ring constriction, right? Both are classical findings. If an exam, if they mention apple core lesion seen, which means they are mentioning that there's a history of colonic tumor, mostly in the left-sided colonic cancer. Fine, perfect. So we know the gross, we know the etiopathogenesis, we know the clinical features. Microscopy. Microscopy is adenocarcinoma, right? Malignant glands, same four features, and invasion into underlying tissue. The moment it goes into lamina propria, LP is lamina propria, I consider that invasion. But there's a clue. If microscopy has too many lymphocytes involved, that's a clue for Lynch syndrome, right? too many lymphocytic infiltration within the tumor, I suspect a Lynch syndrome related pathogenesis. Marker, two markers. CK20 is positive in every lower GI tumors. Lower GI tumors is any tumor beyond ligament of Treats. There's one more marker called CDX2. That's also an amazing marker for colonic adenocarcinoma. If you want to add this also, SAT-B2. That's also a very good marker. And write this as well. MSH, MLH, IHC, if they are negative, suspect Lynch syndrome. Because in Lynch syndrome, what happens? The gene is not functioning. If it functions, it's normal. MSH, MLH is negative, which means the mismatched repair genes is not there. Then it's Lynch syndrome, right? Generally, we call IHC for positivity. This is an example where negativity is important. Same for E-cadherin. E-cadherin negativity is important, not positivity, right? Perfect. That's for your colonic tumors and colonic adenocarcinoma. Clear? We have done decent amount of things in the GIT. We saw gastritis, we saw gastric tumors, we saw celiac, we saw inflammatory bowel disease, we saw colonic tumors as well, right? Some of you asked me about the ulcers. I think Miran asked for it. I put in the last. Fine. Now let's go to liver. See, liver with respect to your CBME is very limited. One of the important questions in liver, if you ask me, is an undergraduate should know about hepatitis. I have told that in the class also. Now also I am repeating it because that's right. Hepatitis, right from microbiology. There is almost zero pathogenesis or zero biopsy requirement in hepatitis. It's diagnosed with serology. You know the organism. Pharmacology, write the treatment. Enough, sorted. There are few one-liners. Ground glass appearance, hepatitis B. Few things. Bridging necrosis, fibrosis, chronic hepatitis versus acute hepatitis. Interface hepatitis, chronic hepatitis. That's all, fine. Siddhi, I'll talk about salivary gland tumors for sure. I have a slide in the last. Least important, I'll talk about it. Acute appendicitis, do they ask questions? It's acute inflammation, that's all. If you want, I'll put a notes. I have not had something for acute appendicitis. If it's a repeated question, I'll definitely put a notes on acute appendicitis. Fine. Okay. Perfect. Let's come back to this. Those are the only things which are required from hepatitis with respect to pathology. Because honestly, as a pathologist, I never get biopsies for hepatitis. It's already diagnosed, already treated. That's it. Right? So it's very unlikely for me to ask something on hepatitis. We'll talk about your jaundice. We'll talk about hepatic tumors. The new molecular classification of hepatic adenoma can come if someone is more interested in the recent advancements in your university. We'll talk about hemochromatosis Wilson's disease, metabolic syndromes. Someone asked me in the group about cholecystitis. We'll just have a look at cholecystitis also. And then we have salivary gland tumors and the others. Fine. Okay, let's go. This is your first year. Whatever I must have read in the first year, right? Bilirubin is not formed in the liver, it's formed in the spleen. Because of disintegration of your RBCs, it's a heme degradation product, right? From there, bilirubin will be bound with albumin. This is not conjugation, by the way, this is just a binding, that's all. Binds to albumin, goes via the splenic vein, joins the portal vein and reaches the hepatocyte. The moment it comes to the hepatocyte, it is unconjugated still. Albumin binding is not conjugation, it is only binding, right? Okay. So now the unconjugated bilirubin, the moment it enters hepatocyte, it has two conjugations with UDP. UDP glucuronide transferase is the one which conjugates them and converts to conjugated bilirubin. The moment it becomes conjugated bilirubin, lipid or water? It's water soluble. That's all. If it becomes water soluble, it cannot escape outside of the hepatocytes because hepatocyte is made of phospholipid bilayer like any other cell. So what do I need? I need a protein to get outside. That's your MRP, multi-drug resistance protein 2. Okay. Because with the help of the protein, it comes to the bile canaliculi. You know what will happen? Every hepatocyte will produce bile like this, unconjugated bilirubin, which comes to the bile canaliculi. All the intrahepatic bile ducts, everything will join and come to the gallbladder. In gallbladder, bile is not just stored, bile is actually concentrated. That's the job of gallbladder. That's the reason when I concentrate something more, there's a chance of them becoming crystallized in stone formation. That's why gallbladder calculi is more common than hepatic calculi or CBD calculi because that's where it's concentrated, right? After that, it will be sent into the intestine using your ampulla of water, the duodenum. Then you remember the intrahepatic circulation, stercobilin and urobilin, it will be excreted. That's all, right? This is normal. If you know normal, abnormality is a piece of cake. Jaundice, if a question comes on jaundice, a 5-mark question, write what is jaundice. Yellowish discoloration of skin or mucous membrane due to increased level of bilirubin. Icterus will be seen mostly more than 2 to 2.5 milligram per deciliter, but even something more than 1.2 is abnormal. We call them latent jaundice. Up to 1 is only normal. Anything beyond that till 2.5, where there's no symptom, we call it latent or subclinical jaundice. Fine. How can I classify? I can classify with a type of bilirubin. Conjugated hyperbilirubemia, unconjugated. With the help of cause. Need not elaborate on this, but just remember, it's very simple. Na? Hemolytic anemia. More bilirubin produced, obviously you'll have more bilirubin there. That's all. Bilirubin is produced by hemolysis. Hemolytic anemia will produce more bilirubin. Liver cannot conjugate all, so you'll have more unconjugated hyperbilirubemia. At the same time, obstruction. Everything is normal, not going outside. It could be your gallstones, obstruction. It could be your ampulla of water malignancy, which means it could be your pancreatic head cancer. It could be your duodenal cancer, not letting them outside. Causes conjugated hyperbilirubinemia, and one of the important clues is pruritus. Because it goes outside, because of obstruction, it will enter into the blood circulation very easily and very early. And that irritates and causes pruritus, right? Conjugated hyperbilirubinemia, we also call them cholestatic jaundice or obstructive jaundice. Hepatic jaundice can have multiple causes. Can have all the hepatitis will have it, right? Name any hepatitis, it will involve jaundice. Alcoholic liver disease will have jaundice. Hepatitis A, B, C, D, E will have jaundice. Everything will have jaundice, right? Wilson's hemochromatosis will have jaundice. Inflammation of hepatocytes will have jaundice. At the same time, we have the syndromes. Syndromes are also a component of the hepatocellular jaundice, right? And we divide the syndromes into two major groups. We call them a defect in conjugation and defect in excretion. The reason for dividing here is, I have a person who is having a defect in conjugation. Can anyone tell me what is the type of jaundice they'll have? Conjugation is not happening. So, conjugation is not happening. So, obviously, they'll have unconjugated jaundice or unconjugated hyperbilirubinemia. I used to tell you, I remember this as conjugation is gone. C and G, Krigler-Najjar, Gilbert. Other is excretion problem. Conjugation is happening, not excreting properly. I'll have conjugated hyperbilirubinemia. That is Rotar and Dubin-Johnson. The good thing is, one of these two, in both of them is asymptomatic. Gilbert and Rotar is asymptomatic most of the time. Slight fluctuations can be there. It's not damaging much. Krigler-Najjar, Dubin-Johnson can really cause some problem, right? Then we'll go to Krigler-Najjar. So in Krigler-Najjar, it's either reduced or absent enzyme UDP glucuronide transferase. Type 1, where I have zero enzyme, autosomal recessive. Type 2, it's a conflicting thing. Most of them say it's autosomal dominant with incomplete penetrance. Some say it's still autosomal recessive, but they have partial presence. That's all, right? So I put both. I will prefer this because that's the latest school of thought, autosomal dominant with incomplete penetrance. Type 1 is zero enzyme activity. Type 2 is reduced enzyme activity. When there's no conjugation, every bilirubin produces unconjugated. Every bilirubin produces lipid soluble. Can it cross the blood-brain barrier? Yes. Can it deposit in the brain? Yes. I'll pull it down. If it deposits in the brain, just to make you comment, what is the term called as? Bilirubin getting deposited in the brain, what's the term called as? We have a term for it. What is the term called as? We call it kernicterus. Kernicterus is difficult to manage. We will lose the child. Autosomal recessive inheritance, presence very early in life, presence at birth, right? Kernicterus, and this baby cannot live. Very early neonatal jaundice, most of the time, almost 100% fatal. Because I cannot replace the enzyme lifelong, not possible, and it's very, very expensive, right? Then your type 2. Type 2 Krigler-Najjar, I have reduced activity. It's reduced activity, still I have unconjugated bilirubin because not conjugating properly. But here I can actually treat. How do I treat? This UDP glucuronide transferase is a CYP enzyme. So how to increase the activity of a CYP enzyme? Use the drug side effect. We had pharmacodynamics, no? We always think that is a useless chapter, very theoretical chapter. Important because I can use the phenobarbital, which is an enzyme inducer, which will increase the activity of enzyme, and the patient can have a near normal life till they die. Can be completely normal till they die, right? And in both these places, it's unconjugated bilirubin. Do you think the bilirubin will stay inside the hepatocytes or they'll escape? It's unconjugated only. They'll stay inside or they'll escape? They'll not stay inside. In both of them, the liver biopsy will be absolutely normal because they come inside, lipid soluble will go outside. They won't stay inside the hepatocyte at all. It'll be purely normal liver biopsy. That's your Crigler-Najjar syndrome. Fine. Next is, again, we are going for the clinically relevant one, Dubin-Johnson syndrome. Dubin-Johnson is an excretion defect. Where do you have a problem? If you remember in the normal, I have MRP2. That is a problem. The exit protein is gone. It's defective. Because of the exit protein defective, conjugation happened. They stay inside the hepatocyte. So you'll have intrahepatic cholestasis, a classical finding. They keep on accumulating inside the hepatocytes. They stay inside the hepatocyte. They keep on accumulating inside the hepatocyte. At some point of time, when the hepatocyte rupture, the bilirubin enters the blood. That's how they cause icterus or they cause jaundice. Fine. That's how they're going to cause jaundice. As simple as that. Conjugated hyperbilirubinemia. The thing is, this MRP2 is multi-drug, not only for bilirubin. So many other things which are supposed to be transmitted by this guy cannot transmit. Lipomelanin is one such. Norepinephrine byproduct is one such. So they also start accumulating. That gives a black color deposit. This is an MCQ. This is a Viva question. Do remember. Black liver, diagnosis of Dubin-Johnson syndrome. So what do we have in liver biopsy? Here actually liver biopsy will have findings. You will see black deposits in the liver and also you'll have intrahepatic cholestasis. The golden brown pigment of the bile will be there in the microscopy. That's what you see in Dubin-Johnson. Again, treatment is not possible for any of this genetic disorder. Fine. Okay. Roshni, it will be in the WhatsApp group. Ask your friends if they are there in the group or it will be in the PW Med channel of Telegram. Fine. Then we'll have a quick look at the other two insignificant guys. Gilbert and Rotar. Gilbert came in last year FMG exam. It's a very difficult question. But the only thing we can identify is family history, young age, waxing and waning course. They are not always they will not always be icterus. Sometimes will be icterus, sometimes will not be icteric, right? Because here I have reduced production of glucuronide transferase, not zero, like 10-20% or 40% reduction. They can have an amazingly normal life. This patient will have definitely will have increase in unconjugated bilirubin only because of conjugation problem. Clinical features, it will not have icterus. It's most of the time asymptomatic or occasional episodes of icterus. Like when there's a stressful event, the person fell down, there's a bleeding, this body won't be able to take care of it. There's an extra requirement, right? That time you'll have icterus, otherwise you'll not have icterus in Gilbert syndrome, right? Then we'll go to Rotar. Rotar syndrome, if you can remember that SLCO 1B1, 1B3, great, or otherwise remember anion transporter defect. What happens here is, most of the time the bilirubin goes outside via MRP. Some of them will spill and come back. That reuptake will be a problem. Imagine that 90% of them will go via MRP2. Some 5-10% will be requiring a reuptake via this organic transporter. That will be a defect. If 5 to 10% is a defect, it's not a defect at all. Here I'll have conjugated hyperbilirubinemia and it's almost always asymptomatic. Okay. Unless until we investigate, we won't be able to pick up Rotar syndrome at all, right? So these are the 4 syndromes of hepatic jaundice. We know the normal, we know when to call it jaundice, we know to classify based on the type of bilirubin, we know to classify based on the cause, and also we know to classify the base of syndromic jaundice. Fine, perfect. Okay, now let's go to the next guy. Next guy, what we're going to talk about is alcoholic liver disease. Question time. Can you answer? Which is the stage of alcoholic liver disease which is irreversible? I'll keep asking questions. I want to get an answer. Which is more damaging in alcoholic liver disease? Is it alcohol or is it acetaldehyde? There's one finding which is classical for, I won't say classical, but is seen in case of alcoholic hepatitis. What is the finding? Microscopy will have pinkish deposits. What's the finding? Yes, Nias, it can. There is a name for alcoholic cirrhosis. What is the name for alcoholic cirrhosis? It is Linitis cirrhosis, right? Perfect. Cirrhosis is irreversible. Definitely. Acetaldehyde is the problem. Alcohol is not the problem. And the pink color inclusion is your Mallory-Hyland or your Mallory-Denk bodies, right? And Linitis cirrhosis is the name for alcohol-induced cirrhosis, right? Alcoholic liver disease can come in an exam. Cytokeratin deposit the. Okay, Roshni, I'll ask them to put it there. Fine. Okay. Let's come back to this. So we have alcoholic liver disease. There'll be an easy history of a person who's chronically taking alcohol. That is the reason. And the patient is having reduced liver function. Automatically, you can easily diagnose alcoholic liver disease. At 3 stages, fatty liver, definitely reversible. Alcoholic steatohepatitis, again reversible. Cirrhosis, an irreversible one, right? Steatosis, what's happening here is, when anyone consumes alcohol, alcohol is converted to acetaldehyde. This acetaldehyde conversion requires your enzyme alcohol dehydrogenase. Whenever any dehydrogenase functions, I'll have NADP, NADPH produced. Here I'll have excess NADH produced. This increase in NADH, okay, Roshni, it's available in the app. Please download the app, fine. This increased NADH will cause all these problems. Triglycerides will increase, fatty acid oxidation will reduce, and the triglycerides start accumulating. That's what causes fatty liver, fine. As simple as that, right? So it's excess amount of NADH. It's a metabolic alteration which causes fatty liver. There are 2 types of steatosis, macro and microvesicular. It'll have both, but ultimately everything will become macrovesicular steatosis only, fine. Okay, so you'll have clear deposits. The difference between macro and micro, in macro, the nucleus will be in the corner. In micro, nucleus will be in the center. You'll have multiple tiny vacuoles in case of a microvesicular steatosis. Alcohol can have both. I'm not going to differentiate based on that, fine. Gross fat is yellow, that's all, right? So enlarged yellow color liver is fatty liver. On touching, it will be greasy. Greasy cannot be seen. On touching, you can have a greasy sensation because fat will have a greasy sensation, that's all, fine. Okay, then steatohepatitis. The same problem is, like I said, aldehyde is a problem. The toxic metabolite is always aldehyde, which is directly toxic to the hepatocytes. Not only the hepatocyte, that's the one which destroys the heart also. Cardiomyopathy, same cause. So here, it destroys 2 important cytokeratins, cytokeratin 8 and cytokeratin 18. These are proteins, right? Damaged protein will always aggregate. These are intermediate filaments which aggregates into pink inclusion, because when I destroy protein, it becomes darker pink color. We call them a Mallory-Hyland body. Initially, it was named Hyland because I don't know what it is. Then Denk, one more scientist came and said, it is not anything, it is cytokeratin 8 and 18. So we call them Mallory-Denk body. It's a very non-specific finding. You will see them in any disease of liver which destroys them. Conditions where I don't see them, acute fulminant hepatitis. It's so fast, I can't see them. It's removed. Hemochromatosis, again very fast, it gets removed soon. Secondary biliary cirrhosis. It's a bile's problem. It's not a primary problem of the liver, so I don't have in secondary biliary cirrhosis also, fine. So what is Mallory-Denk or Mallory-Hyland? You'll have ropey aggregates of cytokeratin 8 or 18. Yes, you will have neutrophilic infiltrate. You will have steatose also in alcoholic steatohepatitis. Ballooning degeneration is cell swelling. That's all. You see them in any type of damage here, right? Perfect. Okay. The next one, the 3rd stage is cirrhosis. Cirrhosis definition is very important. Cirrhosis should be not just hepatic fibrosis. The most important word is this: Liver is the only organ which regenerates after fibrosis. It's a hepatic fibrosis with nodular regeneration. That's what is cirrhosis. Okay. Cirrhosis has two types, micronodular, macronodular, based on the size. Less than 3 millimeter, micronodular, more than 3 millimeter, macronodular. In alcohol, I'll have both. Alcoholic cirrhosis is both combination of micro plus macronodular, and alcoholic cirrhosis has a name which calls an Linac cirrhosis. That's a name for alcoholic cirrhosis. There are few examples for macronodular cirrhosis is post-viral. Hepatitis also can cause cirrhosis, right? You know, that's a macronodular cirrhosis primarily, fine? Okay. So what happens is, grossly you'll have multiple nodules, and microscopy, you can still see the nodules, and the nodules will be separated by collagen, which can be easily appreciated on a mass on strichrome stain, fine? The pathogenesis is simple, recurrent damage. The reason for fibrosis, you'll have increased amount of etosal activity that increases the myofibroblastic response, that increases the fibrous septa formation, right? Initially, its starting point, okay, of the fibrosis, this fibrosis will be pericellular. Later on only I'll have nodules, right? In the early stages, the fibrosis will be pericellular fibrosis. Do anyone remember the name of this? I'll have fibrosis surrounding this cell, surrounding this cell, surrounding this cell, surrounding this cell. Then it becomes nodule. What is this early stage fibrosis called as? It's like tiny, tiny, tiny holes. We call them as a classical finding called as chicken wire fibrosis. Fine. These are etoscells are normal cells which are there in the subcapsular region. I think its normal function is to store vitamin A, and in response to an injury, they act like the macrophage, convert them into myofibroblast, and cause the collagen deposition, which is primarily the septa. Okay, great, super, fine. So that's in short about the alcoholic liver disease. We have three things. I have not talked more about how this alcohol causes a problem, the difference in ethnicity, the difference in amount of intake, the difference in gender. Add on to it if it's an essay question. That's it. Fine. Now let's go to the next guy. Hepatic tumors. First of all, hepatic tumors are not diagnosed on biopsy. It's a MRI based diagnosis, CT based diagnosis. But when we move to molecular classification, hepatocellular carcinoma is still not important for me, but hepatocellular adenoma became more important for me. Because now I not just telling it hepatocellular adenoma is enough for me. I have to tell them what is the subtype of hepatocellular adenoma. So this might come in a 5 mark. Hepatoblastoma and hepatocellular carcinoma unlikely to be asked. Fine. So hepatocellular adenoma is a benign tumor of the liver. Previously it used to be just hepatocellular adenoma. Now I have multiple subtypes. I have 5 different subtypes. At least remember the name. If you're not able to remember everything, at least remember the name of them, all the 5 different subtypes, right? The first guy is HNF1 inactivated hepatocellular adenoma. HCA is hepatocellular adenoma. Normally HNF1, hepatocyte nuclear factor 1 alpha is HNF, is involved in the embryogenesis of 2 guy. If you have mutation, you haven't modified onset diabetes of young, right? That also is a problem. But when it's mutated towards the carcinogenic problem, I end up having an adenoma. 40 to 50% of them is your HNF1 inactivated. Second one, inflammatory, is also an equal number. So I cannot exactly say which is more common. This is more common in female compared to male. The risk of them becoming cancer is very, very, very limited. So there are few things which are important in microscopy. When HNF1 alpha is inactivated, there is a protein which is related to the gene, which is liver fatty acid binding protein, that is gone. That's why in marker it will be negative. If the liver fatty acid binding protein is gone, fatty acid cannot go and bind and cannot be metabolized properly. So what will happen? I'll end up having fatty change. That's a very important microscopy here. Pleomorphism will not be there because it's benign and they don't cause cancer transformation much, right? Increased cell plate thickness. This you can write common for every hepatocellular adenoma. Normally, hepatocytes will have one hepatocyte, sinus, another row of hepatocyte, then sinus, right? Increased cell plate thickness means I'll have 2 rows of hepatocytes, then sinus. This is tumor, so it will proliferate. That's all as increased cell plate thickness. Very simple, right? That's the first guy. Second is inflammation. Something which you can remember, That's why I call it inflammatory. Interleukin 6 receptor is having a problem. Because of that, there's more JAK-STAT activation. When interleukin 6 is more, you know that it will cause inflammation. When I have a receptor causing inflammation, I'll have systemic inflammatory response, obesity, metabolic syndromes. That's an outcome of systemic inflammatory response, right? Again, this is more common in women compared to men. Moderate risk of hepatocellular carcinoma because inflammation will cause free radical formation, can cause mutation by default. Whenever there's inflammation for quite some time, you'll have more fibrous tissue. Here also you'll have increased cell plate thickness without a doubt. Okay, and there'll be bilirubin destruction as well, right? Blood level, CRP will be elevated. C-reactive protein is an inflammatory marker, and JAK6 is positive, it's an IHC marker. Why? Because JAK-STAT pathway is the one which is getting mutated here. Fine. Okay. It will be there in the FARRE batch, Roshni. Just have a look. Third one is beta-catenin. Where did we read beta-catenin? We read in one syndrome recently. Can anyone tell me? What syndrome did we read beta-catenin? Familial adenomatous polypos, right? FAP. Here, you can see that. It's same. Everything will come back to normal. You see them in APC beta-catenin pathway. So in beta-catenin activated, allow overactivation of APC beta-catenin. Now, I have a cancer syndrome along with that and hepatocellular adenoma, right? Can it increase the risk of cancer? Obviously, there's a high risk of them becoming cancerous because associated with an inherited cancer syndrome. Definitely there will be more risk. If I have more risk of cancer, can I see ATP and microscopy? You will. Again, here also I'll have increased cell plate thickness. That is common. Obviously, beta-catenin is activated, that will be positive in the IHC as well, right? These three are more important, okay? I'm not saying ignore the other two. Other two are very low. See, beta-catenin will be around 10%, other two are 40-50%, rest of them are less than 5%. SNH inactivated, sonic head shock. Have you read about sonic head shock pathway anywhere else in the body? If you remember any CNS lesion related to sonic head shock, yes, no, maybe. If you remember, medulloblastomas, right? So it can be associated with medulloblastomas because medulloblastoma also can have sonic head shock pathway activation. It's a very rare category. The only problem is they have abundant risk of hemorrhages. So while operating or before pre-operative checkup, you have to be very careful. If it causes hemorrhage, intraperitoneal hemorrhage, I'll lose the patient, right? Last but not the least, if I don't have a molecular categorization in the hospital, I cannot categorize. I put them not otherwise specified. Or I have done all the mutations in everything of the above, it's negative. I put them as not otherwise specified. That's all. Fine. Okay. As simple as that. It's a benign tumor of the liver. In general, liver tumors are more common in the women. And these are the 5 new molecular categorization which I want you to remember, right? Then malignancy. Just one important thing about the hepatoblastoma. Hepatoblastoma seen in children, blastoma. You know every blastoma will have small round blue cells. Beckwith-Wiedemann and FAP is where you commonly see them. It's just an additional point if it comes as a long answer. Write about the malignant tumors of the liver, right? Otherwise, hepatoblastoma is not something which is asked for undergraduate, right? Hepatocellular carcinoma can come in an exam for sure. One important thing, if there's a very old examiner, they might ask you write a short note on hepatoma. This term is removed from medical science, but still people who want to trouble you, because the moment you read hepatoma, 50% of you will definitely write hepatocellular adenoma because it looks like a hepatocellular adenoma, right? There is an older name for hepatocellular carcinoma is hepatoma. If it comes, curse the teacher and write about hepatocellular carcinoma. They should not ask it, but they ask it, be prepared for it, right? Hepatoma is the older name. Alcohol is a major risk factor without fail. Hepatitis B and C is also important. This is cirrhosis associated. Whenever there's cirrhosis, you can definitely have more and more mutations because of inflammation, which can result in case of hepatocellular carcinoma. Again, syndromes can also cause it. Tumor marker is alpha fetoprotein. Any question says alpha fetoprotein above 1000, think of hepatocellular carcinoma without doubt. Okay. What do I see in microscopy? In microscopy, again, I'll see the same finding. I will have increased cell plate thickness. There will be dysplasia. This word is important. The next word, there will be capillarization of sinusoids. See, normally liver does not have capillaries. Liver has sinusoids. But if I have to grow big, I need proper vascular channels for blood supply. Sinusoids are fenestrated. It will leak. It's not enough for the tumor to grow. So it automatically becomes a very well-formed capillary or a very well-formed artery, so that it can have good vascular supply. That's very, very important for hepatocellular carcinoma. 3 markers. Heparin is a sensitive marker. Arginase and glypican 3, both of them are very specific markers, very much useful for diagnosing hepatocellular carcinoma. Fine. If I am the examiner, the only variant of hepatocellular carcinoma which I want you to know is fibrolamellar variant, because it's always an outlier. HCC is diagnosed via radiology only, CT scan only. But here, it's a tumor seen in teenagers. No one is going to think of liver cancer in a 25-year-old or 20-year-old. No. Then I might require biopsy. Equal male to female ratio. Till now, hepatocellular carcinoma is seen in men predominantly because of alcohol and hepatitis. AFP, moderate elevation, 300, 400, not 1000 plus. Moderate elevation can be seen even if you drink. Even if you have jaundice, I can see that. Grossly allow central scar. Central scar is also seen in one more condition called as fibronodular hyperplasia, a difficult thing to identify. Microscopy, I have oncocytic cells. Oncocytic cells are cells with abundant pink cytoplasm and fibrous tissue. That's why fibrolamellar HCC. Right? There's a very classical genetic association here. DNA JB1, PRKCA mutation. That's classical for a fibrolamellar variant of HCC. If you want to remember, there's an outlier. For that reason, at least, I want you guys to remember that. Fine. Is it done? Any doubt in hepatic adenomas, hepatocellular carcinomas? Do let me know. If not, let's go to the next guys. Okay. Next are pretty simple. I'm sure you'll answer most of them, right? I'm giving you history. A 25-year-old patient came with an history of diabetes mellitus, and also the patient has icterus. On noticing there were a little bit brown deposits in the hand and the feet. What will you think of? What could be the diagnosis? I've described one particular picture. What is that picture about? Anyone? It's a very classical picture, by the way. Navdeep, if it helps you watch it, because I don't know what physiotherapy students need to know about liver and GIT. This is a classical picture of, come on, I thought you should guys know. Great. Dharmishta, great. Hemochromatosis. Why hemochromatosis? Anyone? Hemochromatosis is the right answer. What is the picture I exactly told you? That's nothing but bronze diabetes. Diabetes with brown pigmentation everywhere in the body. Jaundice intimating there's a liver failure. Classical diagnostic mode of hemochromatosis, right? Perfect. So we're going to quickly talk about hemochromatosis and Wilson disease, the metabolic pathways. Fine. Okay. Let's look at it. Hemochromatosis, autosomal recessive type. There are multiple subtypes of hemochromatosis. At least 2 mutations, remember them. HFE, very easy to remember. Hereditary iron. Fe is iron, right? That's all. Hemochromatosis, HFE gene. And HJV, hemojuvelin, JV for juvelin, that is seen in juvenile hemochromatosis, right? We all know that hepcidin is one of the most important regulator of iron metabolism. I said there are 7 to 8 types, right? Most of the types, what they primarily do is they will reduce the functional availability of hepcidin. The moment hepcidin reduces, do you remember what will happen to ferroportin? Hepcidin negatively controls ferroportin. More hepcidin, ferroportin shuts off. If hepcidin reduces, ferroportin is continuously activated. What does ferroportin do? Push iron from duodenum to blood. So there will be more iron in the blood. It will bind to transferrin. But what will happen when transferrin is saturated? Transferrin has a limit, no? After saturation, the free iron will go in the blood. That is toxic. If you remember, free iron produces reactive oxygen species. It destroys wherever it goes. The first target is liver. because that's where everything happens, right? Liver is the first target, that's the first organ to damage. It's chronic damage by reactive oxygen species, which means primarily TDHF, that's all. You'll have liver failure, cirrhosis, increased risk of HCC because reactive oxygen species, as simple as that. The risk will reduce if I treat, but if I don't treat, risk will be there. It will destroy pancreas also. It will damage and it will destroy pancreas. The pancreatic beta cells are gone. So you'll have diabetes. You'll have type 1 diabetes. Beta cells are gone. Insulin dependent diabetes mellitus. Then you'll have the hemocyanin getting deposited in the skin. In addition to that, it will cause inflammation of the skin. You remember my inflammation chapter. Inflammation of the skin will produce melanin. That's why when you stand in sun, you become black. That's all, melanin, right? So here, we call them brown color skin, called as bronze diabetes, type 1 diabetes plus bronze color skin. The reason is predominantly melanin and also hemocyanin. Not hemocyanin first, melanin first, then hemocyanin. The same iron will go and deposit in the brain. Causes growth hormone deficiencies, causes GnRH deficiencies. Women will present with amenorrhea, oligomenorrhea. Men will present with no sexual characters. The kid might not grow, dwarfs, stunted growth because of damage of the pituitary. And they'll have testicular atrophy. It's due to pituitary damage and not due to iron deposition in the testis. Very important. This also is important. It can go and deposit joints and cause pseudogouty arthritis. Okay. So all these are classical features of your hemochromatosis. It's a multi-system disease. You need a very high index of suspicion to suspect that. If you suspect, very easy to identify. What do? Do a simple test. Transferrin saturation. That's all. If serum iron is elevated, T-sat is elevated, there's no other disease which causes that. It's always iron is less. This is the only place iron is very high, saturation very high. Anytime you see T-sat of more than 45, normal is around 35 to 36. More than 45, you need to do a genetic testing. More than 55 is diagnostic. More than 45, you need to do a genetic testing by default. Fine. If at all you do a biopsy, you will see hemocyanin deposit. And what's the stain positive? Pulse Prussian blue will be positive without fail, right? And for confirmation, yes, I can do genetic diagnosis to confirm HFE gene or HJB gene positivity, right? Can anyone add a point on the treatment? You guys know better about the treatment than me. What's the thing you will use to treat? You have an entire list of drugs which are which are iron chelators, right? You can do a bloodletting, you can do an iron chelator therapy. It's must to give an iron chelation till the patient lives there, right? Perfect. That's about hemochromatosis. Now, let's go to Wilson's disease. Wilson, desferoxamine, right? Desferoxamine, deferricerox, deferriprone, any of those iron chelators you can give, right? Wilson is also autosomal recessive. Wilson is a problem in ATP7B. There are two things in ATP, 7A and 7B, right? Just to remember normal copper metabolism, copper is absorbed from the intestine using ATP7A. Copper binds to ceruloplasmin, apoceruloplasmin to become ceruloplasmin. This binding requires ATP7B, and the ceruloplasmin takes the copper throughout the body. It's like transferrin, that's all. Excess copper, if at all anything there, it will be excreted into the kidney, and 95% of the copper, which is bound with ceruloplasmin, goes via the bile. And this requires ATP7B. This binding also requires ATP7B. What happens in Wilson is, ATP7B is gone, it's mutated. So what happens is, because of the mutation, copper cannot bind with ceruloplasmin. So everything what is formed is excess. And copper cannot excrete via bile because biliary excretion requires what? ATP7B. So whatever copper I eat, whatever copper is absorbed is going directly into the bloodstream. And free copper is always a problem. It causes free radical damage. Same problem like my hemochromatosis. What will happen? It will destroy the liver. Cirrhosis, liver failure, increased risk of hepatocellular carcinoma. Copper has few predilections. That's why we call Wilson's as hepatolenticular degeneration. It will damage the basal ganglia. This will be the symptom of Wilson. Young person with tremor. One of the DD is Wilson. Without fail, think of Wilson. Alcohol, anxiety, thyroids are normal. Hereditary tremor is there, but Wilson is also a differential diagnosis. Then you have the KF ring, right? Casia flesher ring, which can be seen on a slit lamp by an ophthalmologist, right? Perfect. And I also can have hemolytic anemia, a few other psychiatric manifestations also, right? Not that important, but these three are must to know. How do you diagnose Wilson? Wilson is diagnosed on two basic simple things. One, urine excretion is more. Second, your ceruloplasmin is very, very less. Simple, no? Ceruloplasmin is not formed, so it's less. What happens is, whatever copper is coming into the body cannot go here, cannot go into the blood to organs. The only way it can go is urine. So every copper what I eat will be excreted via urine. And this is the best test. Again, a reasoning why question. If someone asks you, why urine is the best test? Urine copper levels. Because ceruloplasmin can be altered in alcohol, in hepatitis, in hemochromatosis, wherever liver is damaged also. But urinary copper is never affected by liver damage. It will be elevated only in one disease, that's Wilson's disease. That's why it's the best test to diagnose Wilson's disease, right? Remember, reasoning why might be a game changer in your exam, not just for university, to understand medicine and take it to your NEET PG INICT level, right? Liver biopsy is gold standard. You do a biopsy, you can identify copper as a brownish material. It will be positive for arsine stain. It will be positive for few other stain, rhodamine, right? Rubionic acid. But the best stain for me is arsine because it's much more easy to appreciate. And treatment is same. D-penicillamine is a chelator and trientine also can be used. And there's one more mineral which I can give. If you have a strong base of biochemistry, you'll know that. I can give a mineral which will compete with the absorption of copper. So that absorption can be reduced. Can anyone tell me what mineral is that? That's also a treatment of a Wilson. I can give zinc. Zinc will interfere with copper absorption. The logic is simple. Only when copper comes inside, I have a problem, right? I'll make sure it's not coming inside. As simple as that. That's also a treatment for Wilson's disease, right? Perfect. We know about hemochromatosis. We know about Wilson's as well. So what we done in liver is, we saw jaundice, we saw alcoholic liver disease, we saw your hepatocellular adenoma, hepatocellular carcinoma, hemochromatosis, and Wilson. Hepatitis, like I said, please read from microbiology. That should be more than enough, right? Now, few outliers. I'm going to talk about few things which you asked me. One is salivary gland tumors. I don't know if they'll ask in a long answer, but Wharton pleomorphic adenoma, commonly it can come in a viva question, at least a 5 mark. Then I'll talk about, someone asked me about the gastric ulcers, intestinal ulcers, amoebic ulcer, your typhoid and your TB. We'll talk about them and a little bit about your gallstones. Fine. First, guys, there are 4-5 tumors in your salivary gland. Fine. Sure, Raviraj, I'll look into it. Pleomorphic adenoma, Wharton's, mucoepidermoid carcinoma, adenoid cystic carcinoma, actinic cell carcinoma. Adenoid cystic actinic cell, if you remember 2-3 points enough. Pleomorphic, you have to remember a lot. Wharton's and mucoepidermoid, you have to remember substantially, right? Pleomorphic adenoma is the most common salivary gland tumor. Second most common tumor is Wharton. I don't know why we need that, but still it came once in a NEET PG exam. I don't know why they asked it. And the common location is in parotid. It's not pleomorphic. It is because pleomorphism is the word used for cancer. It is polymorphous. It has too many cells. Benign appearing epithelium, benign appearing cartilage, stroma. That's why it's polymorphic adenoma, right? So it originates from stem cells because of the mutation in HMG A2, which upregulates PLAG1. We have a reverse differentiation. The stem cell alters the expression and then it becomes epithelial and then it becomes stromal. That's why we have in microscopy both epithelial and stromal elements. We call it polymorphous. You'll have cartilage, you'll have stromal tissue, you'll have proper well-formed ducts and epithelium. Fine. Thank you, Unta. Fine. Now, when you look at the gross of pleomorphic adenoma is 100% a viva question, not just here when you go to surgery also. It's not a very encapsulated tumor. They will have pseudopodal extensions. The tumor will extend like this. Tumor will extend like this. Tumor will extend like this. So what you will do for any benign tumor, you will remove this alone. But the extensions, what will happen? It will recur. Because of the pseudopodal extension, the chance of recurrence is very, very, very high. That's why we don't treat pleomorphic adenoma by excision. we remove the entire parotid lobe, superficial or suprafacial parotidectomy. Because of the pseudopole extension, we cannot just excise, we have to remove the entire normal parotid so that risk of recurrence reduces. Malignant change exists, very little chance of malignant transformation. If it happens, we call it carcinoma X, that's carcinoma arising from a pleomorphic adenoma. Fine. Most common variant is squamous cell carcinoma. Fine. Okay. It's not a teratoma, it is different. That's how it is. Fine. Thank you, Miriam. Okay. That's about your pleomorphic adenoma. Right. Next is Warthin's. If you remember Warthin's, this word, that is enough for Warthin's. Serous cyst adenoma lymphomatosum. That's the other name for Warthin. That's the original name. Serous tumor will have papillary area and as a cyst. Adenoma, benign tumor. Lymphomatosum. In between the papillae, I'll have lymphocytes. As simple as that. Warthin can be unilateral or bilateral. If a tumor, if in a MCQ or in a long answer question, bilateral salivary gland lesion, the first thing I'll think of is Warthin's. It can be unilateral also, it can be bilateral also, right? Fine. More common in men, associated with smoking. You can relate it, right? Dharmishta, that's why we have amazing surgeons. They'll make sure that they will remove the gland without damaging the facial nerve, right? Okay. Associated with smoking, and these tumors are not entering the facial nerve much. Facial nerve involvement will be more common in malignant tumors and not benign tumors, right? So what happens here is the smoke particles enter the salivary gland and they destroy them. And obviously, when something is destroying me, you and me will fight back. The same way salivary gland fights back. The moment salivary gland epithelium fights back, they tend to have more mitochondria. When more mitochondria adds in any cell, they change the color to pink. We call it oncocytic. Warthin's will have oncocytic epithelium only. In spite of that, smoke will destroy everything. And they will form a cyst-like space where all the dead salivary gland material will be there. Every dead salivary gland material, any dead tissue will have lots of lipofuscin granules. That's why they give a term machine oil-like appearance. It looks brownish in color because of lipofuscin. That's why a cystic space, epithelial proliferation, lining by papillary projection, and they won't have some more bodies because they are not true papillae, and you'll have a oncocytic epithelium, and there'll be lots of lymphoid aggregate because it's chronic inflammation due to smoking. Lymphocytes will definitely happen, right? Gross, you'll have solid lesions with machine oil, cystic lesion with machine oil appearance, right? That's for Warthin's tumor. Warthin can be seen in few other places apart from salivary gland also, but predominantly seen in salivary gland, okay? Then do mucoepidermoid. Mucoepidermoid is the most common malignancy in salivary glands. If you have a minor salivary gland lesion, predominantly it's cancerous. A question saying tumor in the lips, minor salivary gland. Think of malignancy more, okay? Still, it's most commonly seen in parotid. Translocation between 11 and 19 is classical. You have to remember them. CRTC1 and MAML2 translocation fusion protein, which causes the mutation. New mutations, do remember them, and they'll become significant in quite few years, right? Mucoepidermoid carcinoma. So grossly, you will see it can be small, it can be big. You will see solid areas plus cystic areas with mucin. It's mucoepidermoid, right? That's all. There are 3 cells here: basal cell, intermediate cell, and squamoid cells. In microscopy also, you will have cystic spaces with mucin. If you see multiple cystic spaces filled with whitish material, pools of mucin, that is mucoepidermoid. This is salivary gland mucin. They are positive for a stain called as mucicarmine. Okay, they are positive for mucicarmine. That's also a mucin stain, like your Alcian blue and PAS. Fine. Adenocystic carcinoma, again, adenocystic and actinic, just remember a few of them. Raviraj, some errors here and there must be there for sure, right? That I will correct. So use the corrected content of that after the lecture in the PW Meta app. So it will be more or less sorted. Fine. Adenocystic carcinoma, it's an epithelial malignancy, not that common, but 2 findings in adenocystic carcinoma makes it important. The classical appearance, Swiss cheese appearance, you'll have multiple holes, or a cookie cutter appearance or a cribriform appearance, and perineural invasion. It can invade the surrounding nerve. That's very classical. CD117 c-KIT positivity is important. Ignore the genetics, not that important for an adenocystic carcinoma. It can happen in multiple organs, can happen in lung, can happen in the thyroid, can happen in the liver, can happen in the breast. But salivary gland also is one of the important places. There's a variant called a solid variant of adenocystic carcinoma, which will not have cribriform appearance and they have a worse prognosis. Just remember, Swiss cheese, cribriform, perineural invasion, you're sorted. Actinic cell carcinoma, I want you to remember only two things. One, it is actinic cell carcinoma. There are two types of salivary glands, right? Just a question. What are the types of salivary glands you know from your anatomy knowledge? We divide salivary glands into two different types. What are they? We call them serous glands and we call them mucinous glands, right? So this is not seen in any place apart from parotid. Very unique to parotid. That's very important. Minor salivary gland cannot have it because minor salivary gland do not have an acini. They are primarily mucinous glands, right? Only glands which have serous acini can have actinic cell carcinoma. That is something which is very important. Major, minor, yes. Microscopically, we call it serous and mucinous. Only glands which have serous acini can have actinic cell carcinoma, which means almost exclusive to parotid. Others can have, but exclusive to parotid, right? And microscopy, what do you have is zymogen secreting cells. You'll have acini with purple granules. You'll have acini with kind of an basophilic cytoplasm. We call it amphophilic cytoplasm. Slightly blue, slightly pink, but predominantly bluish cytoplasm because every zymogen acini will be blue in color only, right? That's classical for actinic cell carcinoma. Fine, great. These are the 5 salivary gland tumors. Pleomorphic and your Warthin is important. Rest are not that important for now. When you go to final year, salivary gland is an important topic in surgery where you will revisit all of them. Fine, great. Okay. Someone asked me about cholecystitis. We'll talk about cholecystitis, right? Do they ask questions on cholecystitis? Tiny chit chat. Do your university exam have questions on gallbladder calculi and cholecystitis? Yes, no, maybe. Yes. Just quickly we look into it. We have two types of gallbladder calculi, the cholesterol stones and pigmented stones, right? Okay. Cholelithiasis is nothing but formation of the gallbladder calculi. Okay. The cholesterol stones has the fat 40 fertile female and a foreign person, right? Fat 40 fertile female, a foreign person is classical for cholesterol calculi. Female, fat, 40, fertile, and fair. Fair is for the foreigner. It's more common in a person who is in the Western population because of the amount of fat they used to consume. Now, India has also come into that place, right? Obesity, rapid weight loss, anyone who's going on a diet, right? They go for diet so crazy that you have to lose 5 kgs in 1 week. You'll end up in having this problem. These are additional risk factors. What happens here is, the mechanism of calculi formation is simple. Bile can hold this much cholesterol. It has a limit. If the cholesterol secretion is very high or the bile is not proper, less phospholipids and the bile is also less, the bile becomes saturated. The moment it becomes saturated, it will tinily form a crystal. That's why I said, that's why gallbladder is a very important place where I can have calculi formation. The moment it starts forming crystal, the flow becomes more sluggish and it keeps on depositing more and more layer, which promotes the gallbladder stone formation, right? This word is important. Nucleation and crystal formation is important. The moment crystal formation is there, gallbladder itself will start moving slowly. So clearance is slow. It will again cause supersaturation, more nucleation and stone formation, right? It's a cholesterol calculi, yellow in color. It's not difficult to remember that, right? It's yellow in color, can be single or multiple. More than 70% of them is cholesterol. Just cholesterol alone cannot form a stone, right? Cholesterol will form ghee or butter. It cannot form a stone. It needs to have some calcium salts. By default, will have calcium salts and few mucin glycoproteins, right? Then we have pigment stones. Pigment stones are of two types. Both black and brown stones. Calcium bilirubinate, and along with calcium source and cholesterol. Black stones are predominantly seen in hemolytic anemia. Any chronic hemolytic anemia, definitely the gallbladder will keep on getting more and more and bile over the period of time. It will cause black stones. Black and they are radiopaque, multifaceted. Brown calculi are seen in biliary infarction. Because when you have infarction, what happens is bacteria's glucuronidase will be there. That will unconjugate or deconjugate bilirubin. If you remember, this is what happens in enterohepatic circulation, right? Tomorrow is holiday, right, real student? Do that. This is what exactly happens in enterohepatic circulation. Glucuronidase, it comes back again. But here, it happens in the bile duct or in the gallbladder because of infarction. That deposits the calcium bilirubinate and you'll have brown color. And they usually in the bile ducts than in the gallbladder calculi because the infections are more common there. Be it an ascaris, be it a clonitis are more common in the ducts than in the gallstone. Fine. Okay. This is what happens here. Symptoms, be it pigmented or cholesterol, will be the same. You'll have a biliary colic, right hypochondrial pain, tenderness and everything. Complication, right, at least cholecystitis, empyema, gallstone ileus. Few things you have to remember regarding the complications of a gallbladder calculi. Fine. Perfect. Just a few words about cholecystitis. I'm not sure if they will ask cholecystitis in exam, but if they ask, as a short note, write about the classification. If you cannot write the entire length, just write acute and chronic. One of the most important things is mention this. Calculus, A calculus is very, very important because predominant of them is calculus cholecystitis only, right? Acute cholecystitis is due to calculi. Reason is simple. I have a stone which can block the duct, whichever it is, the output of the gallbladder or the cystic duct or the bile duct. You will have stasis. You know for a fact, bile is an irritant. It will irritate the mucosa, it will destroy the mucosa itself. It will cause inflammation, it will cause more infection. That's all it's going to happen. That's the pathogenesis of an calculus cholecystitis. The bile is the reason for damage here. But in acalculous cholecystitis, I don't have bile. So I don't have stones. If you look at this, there's one common thing here. Sepsis, ICU, trauma, burns, major surgery. Can I say one of the common thing for all of them is hypotension? Hi, quote and good evening. It is, right? So hypotension is one of the most common denominator here. In an acalculous cholecystitis, the blood pressure reduces. Because of the blood pressure reducing, gallbladder will have ischemia. That will cause stasis of the bile and then bile will again irritate and cause inflammation. That's all. Okay. Acalculous is more dangerous because the problem here is not local, it is systemic. I'm having a background of ICU, trauma or burns. Calculus, the problem is local, right? That's cholecystitis. Symptoms will be similar to whatever you see in your gallstones. Fever along with that, heart rate will be, palpitation will be there, but still there will be pain and tenderness in the right hypochondrium. Gross, I can have edematous. Microscopy, you write whatever you can write for acute inflammation. You'll have neutrophilic infiltrate, congestion, everything, right? Chronic cholecystitis, one word which is important for chronic cholecystitis is this guy. This is the only thing which I expect an undergraduate to know because this can come in a slide as well. Your slides will definitely have chronic cholecystitis. It's nothing but repeated attack of acute cholecystitis, same TDHF. You'll have fibrosis, mucosa will be destroyed, and you'll have contracted gallbladder and causing inflammation. It's TDHF. Gallbladder will be thicker, stones might be usually present, mucosa will become flattened because it's chronic, because there will be underlying fibrosis which will flatten the mucosa. Microscopy, you will have inflammation of lymphocytes and macrophages. But the most important thing is Rokitansky-Aschoff sinuses. What does it mean is, this is my normal gallbladder epithelium. But in chronic cholecystitis, what happens is, there's an extreme increase in the pressure of the gallbladder within the mucosa, within the lumen. Because of this increased pressure, the normal mucosa which is here will be pushed below. Just because of the undue pressure will be pushed below. That's outpoaching of mucosa going into the muscle wall. That's classical for chronic cholecystitis. We call it an Rokitansky-Aschoff sinuses. Remember that? That should be more than enough. And for a Viva question, We have a type of chronic cholecystitis. We call them a strawberry gallbladder. Grossly, you'll have multiple bluish, yellowish spots. The term is cholesterolosis. That's a type of chronic cholecystitis where you'll have your fat-laden macrophages or cholesterol-laden macrophages in the lamina propria of the gallbladder epithelium. That's cholesterolosis or your strawberry gallbladder. Fine. These are few things about your cholecystitis, both acute, chronic, and the gallstones, right? Last but not least, Miran asked me to talk about ulcers of the intestine. Again, I thought this is a practical topic. I'll do one thing. I'll record practical videos and I'll put in my channel because PW has lots of videos there. I'll share the link as well. You can watch whenever it's required. Typhoid ulcers, TB ulcers, amoebic ulcers. The reason I don't talk about them is in this era, typhoid causing an ulcer and me diagnosing them via endoscopy is ultimately will not happen. We know to diagnose them, we can treat them very easily. Same goes with amoebic colitis as well, right? TB, yes, it can happen, right? If they ask a question which you not read, this you know what causes them, write them first. Second, site. Typhoid happens in the Peyer's patches. Most of them will happen in the Peyer's patches. Your amoebic ulcer will happen in the colon. Okay? Fine. Typhoid ulcers are longitudinal ulcers. Okay? They are oval and they are longitudinal ulcers, right? So longitudinal. I used to remember Ty for typhoid. So they are longitudinal ulcers and they are oval ulcers. Typhoid ulcers are generally superficial. They don't go deep and they don't destroy it, right? Typhoid ulcers will have necrosis of Peyer's patches along with macrophages, right? That's classical for typhoid ulcers, fine? TB ulcers, you know, TB are transverse. Tuberculosis are transverse. The reason why they're transverse is, see, it's simple. Imagine this is my bowel. And this is how the lymphatics go to your mesenteric lymph node. And TB always travels via the lymphatics. That's what it is, right? I'll come to it, Raviraj. Right? So the moment it goes into the intestine, it will catch the lymphatics to go to the lymph node. That's why TB ulcers are transverse. And TB ulcers can go any depth because it's TB. TB can destroy anything what it comes its way. Microscopy, you'll have the classical caseous necrosis and granulomas. Fine. Raviraj, how does GI TB affect? There are two reasons. One, drinking an unpasteurized milk because of Mycobacterium bovis. Though it has reduced a lot, but the recent trend, everything being organic, they don't want pasteurization. They go and, I think in future they'll go and directly drink the milk from the cow. Unpasteurized milk can transmit Mycobacterium bovis, but the incidence is reduced a lot. Second reason is, you have conditions called as open tuberculosis. You spit out, the sputum will have TB. Sometimes you don't spit out, right? You swallow it. When you swallow the sputum, along with the bacteria, it goes into the GIT and can cause intestinal tuberculosis. Or third way, miliary. Transmission via the blood, it can go and damage the intestine. These are the only ways it can reach the intestine. Most common cause, an open case of pulmonary tuberculosis who swallows the sputum, goes into the intestine. Clear? Perfect. Next is entamoeba. Entamoeba is amazing. I used to teach them long back, but the relevance is not there, so we left it. If you have to learn medicine, if you have to excel medicine, understand what the terms are talking. Entamoeba histolytica. Histo means tissue. Lysis means lysis. So entamoeba secretes an enzyme, that's a virulence factor of that, called as histolysin. So what happens is, let's say entamoeba enters here into the intestine. It secretes histolysin, starts destroying them. But then parasites, protozoan histolysin, it can destroy, but not strong enough to destroy human muscle. It will stop at muscularis layer. It cannot destroy and go beyond muscularis. It will stop at muscularis. So what happens is, this entamoeba cannot go beyond that, so it goes sideways. That's a classical name of flask-shaped ulcer. Okay, it's looking like a flask. because it cannot go beyond muscularis propria. That's a classical flash-shaped ulcer. Submucosa it will go. Beyond muscularis it cannot go. And this flash-shaped ulcer is seen on microscopy, not on endoscopy. Right? What will you see in endoscopy? This is a microscopic finding, right? Endoscopy, you will see this. In an endoscopy or a colonoscopy, right? Gross finding, what you'll see is pinpoint ulcers. Pinpoint ulcers is the one you will see in the colonoscopy, because in a colonoscopy, you will see only the opening of the flask, not inside the flask. Pinpoint ulcers on colonoscopy, flash-shaped ulcers on microscopy, and it cannot extend beyond muscularis. It generally will stop with this. It will be like that. Only when the organism is very high in number, extremely virulent, it can rupture. That's a complication, not a normal one, right? And you will see amoeba, and the most important finding in amoeba is they'll have ingested RBCs. Amoeba needs to survive, right? They'll eat the RBCs, use them, and they'll survive, right? That's a classical finding for entamoeba histolytica ulcers, fine? Okay, we have longitudinal for typhoid, transverse for TB because of lymphatics, and a flash shape for entamoeba, right? Clear? That's it. Thank you for your time. I think I've covered most of the things required for you from GIT and liver. Tomorrow is a holiday. It's a Sunday. 2 videos. This for today's FARRE and yesterday's FARRE. Please complete it before you come on Monday. Okay? Fine. Monday, we'll be looking at kidney and male genital system. Tuesday, we'll look at female genital system and breast. Endocrine, look at it, Raviraj. Sometimes down the road, definitely I'll do it as well. Fine. Thank you guys. Thank you for your patient listening. See you on Monday. Till then, bye-bye.